and I will make you the host just before I leave, okay?
Perfect. I think Katrina said that 58 people had signed up, Jane, so we need to just wait a few more minutes.
Sometimes the Zoom takes consenting and coming in.
Yeah. I think people are getting used to the slightly complicated system of several emails from the BPNA, because it is that it'd be fair to say there are stages, wouldn't it, Katerina? I think there's 3 stages altogether to successfully logging on.
Yes, exactly. Well, sadly, you have to first book your, you have to first book your place, and then closer to the date of the meeting, I have to send out the Zoom link manually to everybody, and then another registration.
Yes, and then you send the final link, don't you?
Well, we are hoping in the future, within the next couple of years, to update this system that we are using, and hopefully we will get something much more sophisticated that will maybe help us avoid all
perhaps
these
only have
steps.
2 steps rather than 3.
Exactly, yes, that would
be
make
good.
sense. Let's see. That's the aim. We'll work on it.
Yeah. It's only going to take a few minutes to do to introduce the meeting, isn't it, Jane? So maybe if we give everyone till about 2 minutes past 10, do you think?
Absolutely.
Jane, I just made you the host now, okay?
That's fine. Okay. Okay, Peter, I think we should begin to start the meeting.
Okay. So welcome everybody. Thanks very much for coming. I'm delighted to be back. Some of you may be aware I've been off sick for a few months and in fact missed the last meeting, which is a great disappointment. Jane's really kindly organised this meeting, so I'm going to hand over to her because she's going to introduce the theme, which is around the rehabilitation of patients with brain tumours. Jane.
Good morning all, and it's very nice to see you, and thank you for giving us your time because on this very important subject. So I'm sure you all feel as passionate about it as we do. Further to our last meeting hosted by Oxford, we now today have a meeting being the last one on technological advances in paediatric neurorehabilitation. This meeting's theme is looking at children who have had brain tumours and the recovery process. Just like other children with acquired brain injury, we know that this group of children may have successful neuro-oncological treatment, but then be left with significant morbidity. And given that the mortality is decreasing in this group of children, we're seeing more children living long lives then with an acquired brain injury secondary to a brain tumour. So given that, we're delighted to have 3 speakers before our comfort break, all which are keen to share their knowledge on this subject. And the first speaker is Helen Spadeas. The second will be Tash Cornwall from the Tessa Jowell Foundation, and the third, Shona Mackey. Let me introduce the first speaker. Helen is a paediatric endocrinologist, particularly working in neuroendocrinology, and has worked for many years at Great Ormond Street Hospital. Given her experience in this subject, she has noted from her position as a neuroendocrinologist the plight of children who are in this group of having had a brain tumour and the challenges then in relation to the recovery process. And she has gone a further step by founding a charity called Success. So we want to hear about this charity, hear about Helen's suggestions, and we are delighted to welcome her today. And may I say, she's actually stepping out of her holiday, and she is speaking to us from Greece. So she's probably got better weather than the rain we've experienced here in the last 24 hours. Helen, may I turn to you? Welcome, and we're delighted to hear you speak at the Paediatric Neurorehabilitation Meeting of BPNA. Helen.
Thank you so very much, Jane, and for the opportunity to actually speak to you today. It means an awful lot to me because, as Jane mentioned, I've been a paediatrician for 43 years. And in those days, we used to work holistically, but subsequently we've all subspecialized, and my interest became endocrinology, and increasingly in children who'd survived cancer and then brain injury. And that's what my original thesis was on the effects of radiation on the brain, because everyone thought it was radiation that did all the damage. And over the last 20 years, I pioneered a kind of service at UCL and Great Ormond Street to try and look at increasing numbers of children treated with brain tumors. And then I began to get further and further deeper into it as we realized more and more survive, and realized that actually there was more than just dealing with the thyroid and the infertility and the glandular problems, but actually deep brain injury to the deep midbrain, which I've increasingly concentrated on. And that's led me to work with neuroscientists as we've become more and more specialized. I've learned a lot from my patients. And I got so frustrated seeing more and more of these children receiving more and more treatment without actually getting the holistic care they needed. I think everyone assumed somebody else was doing that. That when as I approached retirement, I set up the Success Charity. It's a voluntary effort with parents and other professional trustees. No money, just loads of passion. And now we have a bit of Elaine as a part-time administrator. And I'm going to tell you a little bit about why we exist. As far as I know, we're the only charity that aims to give the survivors a voice. So yes, about 70% have long-term problems, fits, psychological problems, vision impairment, hearing impairment, motor impairment, speech impairment, swallowing impairment, paralyses, long-term mental health problems, hormone deficits, many of them of which are life-threatening. And many of them have multiples of these. And whilst a bit of endocrinology is being supported, it's not streamlined, and it's getting more and more needed because we put more and more treatment and more surgery and more chemotherapy, which actually hasn't always worked as well as hoped and hasn't stopped the tumor growing. We pride ourselves on trying to be the voice of the survivor. We look at children, take children, and we've increased our diagnostic beneficiary parameters to say we support any child or young person who's been diagnosed under the age of 25. You may know, and I've recently learned that the brain doesn't stop growing till then, and our developmental processes don't. So that's the opportunity, and a lot of cancer care, and we will support them lifelong because we believe that having an injury in the developmental years is very different from having a brain tumor or brain injury once you're post-mature. And the ethics are different too, and the survival rates are different. So some of our survivors are young, some of our survivors are old. We also aim to consider the families and carers as our beneficiaries, and also our professional colleagues, because we're terribly keen to share learning and also create educational opportunities for what is increasingly becoming an entirely new specialty, I think. And we can't just dump it into a survivorship long-term follow-up clinic and expect some poor nurse to deal with it, I think. I think we really need to try and get some further understanding of what really is not a long-term treatment effect, but a brain injury. So I'm going to start by hoping that I can let these young people speak for themselves.
Video, which is just
if I can do that, and start the. Let's see if we get this.
It feels very exciting and slightly nerve-wracking, but it feels like I've just about got everything together, and I'm hoping it runs smoothly.
Most about today, what I'm really looking forward to is really meeting everyone again, because it's been a long time since we've really got to see each other and talk to each other and, you know, actually meet up as, well, we say a group, but really I see us as a family, so yeah.
Meeting other people that had cancer and seeing what was going on, I guess.
Hopefully get a friend or two out of it.
survival to me means I've been given a brilliant opportunity, having come out of something that should have left me a lot worse off. So I'm going to use it as what a friend of mine described as a superpower. It's given me a clearer mental picture on what I can do. I'm mentally stronger. I'm physically, I'm getting there. I want to go forward and help people and do what I can do with it.
Knowing that I was the age of 6.5, I went through mine, and then I'm now in my 20s, and I can't believe I'm still here, you know, it's still here, loving life. I have a massive scar on my head, and I had to. How I got the scar was the nurses had to cut open my head and take out all the blobs, and then I just got left with this massive scar, and yeah, so on my head. So yes, that's my story.
This is my 3rd year. I went to my first college, which was in Southgate, for 2 years. And now I'm doing level 2 hospitality services, and I'm really enjoying it so far. And in April, I go away for 2 weeks with my course in Malta to work in a hotel for 2 weeks. So it should be a lot of fun. I'm enjoying it so far.
Well, I have a great one for Dr. Spadeus. If it wasn't for Dr. Spadeus, I wouldn't be this small. I was like this small. But Dr. Spadeus called the other doctors to get me on the growth hormones. And she's sort of my hero.
I feel like I've got more of an insight about patient skills. So since I was younger, I've always wanted to go into medicine or be a clinician of some sorts. And I am now, I'm a physician associate in the NHS. I work in a GP surgery. I feel like I've got more of an idea of the patient side of things. I think just going at the whole clinical side, you have to be this to do that. Understanding what the patient is possibly thinking and feeling first.
As a survivor, I think success means being more than just the patient. It means being more than just the medical definition of a brain tumor survivor, someone who's lived 5 years after cure. There's a lot more to survival, because I think a true survivor or true survival means living. It means taking that life that you've been given after medical treatment and doing something with it. That's what being a brave heart is all about. It's about, you know, finding the courage to move forward with your story, to turn it into a learning experience, but also acknowledge the fact that we can do things to make it better for other people.
Hey, it's good. It looks like it makes me feel like a powerful warrior. Like a knight in shining armor about what I've been through.
Before success, I tell you the truth, I was the only one, you know, my age that had a brain tumor, and that wasn't really a nice place to be at. But thanks to success, I actually feel like there are more people around that are more in my circle, and I actually feel like, you know, they're family to me now. Yeah.
To me, success makes me feel like I'm someone big. Like I can't. For me, I'm part paradise for my life. I've got learning difficulties, but like I won't be able to be someone big. I won't be able to be I can't work for life. Over here, it makes me feel like I'm someone really special. Like I've got powers. Like some people look up to me over here.
If anything, what I've been through is there's no such thing as failure. Failure can come in so many packages, you know, and people interpret it in so many different ways. And obviously my failure was, you know, having brain cancer. But, you know, with every mistake you make, you know, you learn something from it. If I spoke to the Prime Minister, I would want to raise awareness of all these side effects that are just glossed over when you have a brain tumor, because no one really understands it. I mean, I didn't understand. I'm still learning. I'm still learning how my tumor has affected me and will go on to affect me. And that is what I think we are missing. We're missing people understanding that a brain tumor isn't just something that can be taken out. It lasts with you the rest of your life.
That's a massive thank you. I owe a lot to you.
If it wasn't for success, I don't think I'd be here. I don't think I would have figured out myself. I would have probably just been a depressed person, depressed child.
They are quite inspirational. and they've certainly taught me a lot. And we have we've been having an annual conference now for this was our 6th, and you can see all the videos. It's very much for survivors, by survivors, but with professionals and acute decision makers. And this March we had parliamentarians. We had a nice debate chaired by Dominic Grieve, our patron. We've got 3 parliamentarian parents in the House of Lords who are supportive. And I think that we are beginning to get this rather Cinderella area out of the ashes and into the ballroom. But you can see the webinars are all on our YouTube channel. And if you subscribe on that if you just contact us, we'll invite you to our events, and we'd love you to attend. So the next conference is on the 2nd of March at the Royal Society of Medicine. We hope it's going to be the biggest, and we'd love to share some of the content with you and have you on the organizing committee. And we're also doing a Birmingham roadshow, which is our first involvement outside of London, because we do very much want to be a national charity. We only launched as a national charity just as COVID hit. So we're making slow progress, but we'd love you to, and we have quite a lot of information for families and for professionals that we're beginning to add on the website. So why has this become an increasing problem? Well, because everyone thought that children with cancer died, and actually that's not been the case for a long time. And before 1999, I would say, the Children's Cancer and Leukemia Group had well-organized services for children's cancer, and their definition was before their 15th birthday. Since then, there's been an increasing move through the National Cancer Registration and Analysis Survey to take those data registries and create an adolescent, teenage, and young adult from 15 to 24. And those 2 data sets have now been combined, and with a little bit of government initiative, we are now beginning to get some statistics that are maturing. And the first combined statistics for 0 to 24 was coming out just in 2021. And what I think you can see is that if you combine all cancers, and you can actually look at them separately, you can look at them combined, and they do give different information. And one needs to have lots of people to analyze this. I think there's a lot that you can do that I haven't done, but you can see that over the last 20 years at least, and we haven't, with all the millions that we've spent on cancer care, we haven't changed the short-term survival. And there's a long-term deficit, which the recent years haven't really had time to mature. And it's not that different from brain tumors taken as a separate group. And brain tumors and spinal tumors are the 2nd most common cause of cancer, secondary to leukemia and lymphomas. So it begs the question about what is a cure, because traditionally cancer statistics, you've got a malignant tumor, it's going to run away with itself. So if you live 5 years, that's a cure. You don't have to live 5 years disease-free. You just have to live 5 years. You don't have to live 5 years treatment-free. But if you live 5 years, that's a cure. But you don't get into long-term follow-up clinics until you've been stable off treatment for 5 years. So you can see that the numbers accrue, and some of these children are not getting into any survivorship service, and the survivorship service they're getting into is one that's largely for broad cancers, which I would say are not the same as having one in the brain. And if you now look at the different tumor statistics themselves, so initially all brain tumors were lumped together, but now we've been looking at malignant brain tumors. So not all brain tumors are the same. And I will start by saying that most brain tumors are not actually malignant. They're not malignant by pathology or histology. They're malignant by virtue of the damage they do, usually to the endocrine system. So they kill in different ways. So the assumption that they kill because they spread in a cancer way is, I think, wrong to start with. And where we started was medulloblastomas and ependymomas, and they are malignant. And they were treated with surgery and radiotherapy in the old days, and we got up to about 60% survival rates with that. And they haven't really changed that much. I mean, in the children, you'll see a better statistic. So if you separate this out between 0 to 15, 15 to 24, you'll see it better. So some of the what's called sensitivity is lost in the data blurring. But these ones are in the periphery largely, in the posterior fossa or in the supratentorium, and they are surgically accessible on the whole. In fact, ependymomas, people would say, is a surgical disease, and they have a long life. But the ones that are in the deep midbrain and malignant are not accessible easily by surgery and have relied largely on radiotherapy. And actually, again, I should separate these out by 0 to 15 and 15 to 24 because they're more common in the adolescent age group. There's an age spread. And traditionally in the adult group, they were treated by endocrinologists because they affect the posterior pituitary, and the cardinal sign they present with is diabetes insipidus, which was one of the low-down criteria on the Head Smart campaign that David Walker put in to try and get earlier diagnosis, but it's often missed. So polyuria and polydipsia is not always diabetes mellitus. It may be the sign of a brain tumor. And they're very amenable to radiotherapy. But because radiotherapy was blamed for a lot of the outcome, it hasn't been used in the under 15s. But if you go to an adult service, you will still get radiotherapy. So there's lots of sort of controversies and contrasts that have arisen because of this feeling that radiotherapy is all malign and chemotherapy and drug therapy is all benign. And I would like to change that. The second thing is that oncologists talk in terms of tumor histology and molecular biology. And these so-called benign low-grade brain tumors wax and wane and may be developmental. And these pilocytic astrocytomas are very low grade, and they can occur anywhere in the brain. And if they occur where they can be taken out surgically, as the young girl in the hat has, she needed 2 goes at it, and she has had radiotherapy, and she's still got an IQ of 140. So radiotherapy doesn't necessarily knock you off, and it's a very good treatment strategy, but she never got much rehabilitation at all because she's very high functioning to start with. And her tumor was operable in the brain stem pontine lower. They left a little bit and then they gave radiotherapy. If it occurs in the optic pathway and anywhere from the anterior globe through the pituitary hypothalamic area into the optic cortex, you can imagine it can occur anywhere along there. And even if it's well away from the pituitary, it was thought not to cause damage, but it does. And I will show you some data on that. But these are the ones that we haven't been good at curing, but they're still very high survival. And if I just move that across, you can see that there is a late death rate. And that death rate is not necessarily tumor recurrence because they tend to stop growing after adolescence. It's usually tumor hemorrhage, bleeding, something catastrophic into the deep midbrain, operation to try and debulk, or just late endocrine deficits, adrenal crisis, and things like that, which are not recorded as such. And as a result, because I was seeing more and more children with worries, these are even rarer. but they are right in the pituitary region. And these children, these adults with pituitary tumors are treated in adult pituitary care services with specially commissioned surgeons and endocrinologists leading care. And that has not been the case for children. These children have been seen in pediatric neuro-oncology centers and endocrinologists running about trying to access adult services. And the late death rate, again, is endocrine, much more than disease. So we've been struggling to analyze those separately. So I would say that the forgotten facts, of a brain tumor are that, as I said, cure does not mean that you've got rid of the disease. In fact, most children with benign tumors will not get rid of the disease. It's only true for the malignant ones. But nevertheless, 80% overall now live long lives into their 70s. And the question is, how is that life led? And why did we cure them in the first place? Wasn't it to give them back the life? And most of these tumors threaten life not by dissemination, but by intracranial pressure symptoms, which are often present before diagnosis. There's evidence of focal disease, which I've learned from my neuroscience colleagues is more adaptable to rehabilitation than global disease. And I believe that a lot of them are affecting the central connections through the deep midbrain, which are part of survival itself. And I see it increasingly in children with traumatic brain injury as well. Nevertheless, the focus has been pharmaceutically driven, drug driven, new developments, molecular biology driven, and it's hugely costly for the NHS, for the survivorship services, whereas, and it probably only adds 5% benefit to the survival. And in order to get that 5% benefit, you have to treat the other 95% the same way in order to run these trials, 20% of whom will still die, and 80% will now live with more toxicity than before, some of them having had salvage radiotherapy because the chemotherapy just does not work. And if you are brave enough to say that to an oncologist, they'll tell you there's another drug on the block and we must do this trial, but every child must go into the trial. And so you are actually preventing choice. And I think there is an ethical question here, which says that we should not, now that we cure 80% of children, we should not be offering them a cure. We should not be touching their brain tumor unless we can also cure the brain injury, which has been misattributed to treatment and radiotherapy and needs rehabilitation in its own right. And I think that's the argument we have to put to the commissioners and to the NHS England and the trusts, but it's not an easy one. The other thing is that I believe it's the tumor location that dictates the brain injury, and I suspect you would be with me on that, and that it's different in the developing child than it is in the adult. So a post-mature adult who's done all his growth and development and education and hormone support and pregnancy and fertility has a very different need. And sadly, their brain tumors are often malignant if they're not in the pituitary than a child who is still developing. And not to put that into the mix and look at those children separately is wrong, as indeed Hilary Cass is saying on another topic that's very controversial at the moment, which is gender identity disorder. You know, hormones and the brain and development are exceptionally important to the growing child and neurodevelopment. And she's a neurodevelopmentalist, of course, as you well know. There is an increasing feeling across neuro-oncology that some of these benign tumors may actually, and some of the malignant ones, that they're all different from tumors in adults. And some of them may be developmental. We keep changing their definitions, but there's no doubt that you see different trends if you separate them out by group ages, 0 to 15, 15 to 25, and there's a lull somewhere. and then they start up again at 50. And there's a lot of work to do in terms of the adult malignancy, because they are almost universally fatal, except I would remind you pituitary tumors, which no neuro-oncology team seems to consider in the adult world, because they've been looked after by pituitary specialists and have specially commissioned pituitary services led by endocrinologists and pituitary surgeons and pituitary centers. And so they don't feature in most neuro-oncology services. And I'd be interested to know whether Tessa Jowl have included them as part of their brain tumor category. They're actually outside the brain, by the way, connected up into it. You can catch them through the nose, which is why. But they are malign in terms of the endocrine harm. So what we've been trying to do since 2010, and it's been a real labor of love, is I've been trying to knock heads together across societies and disciplines to create endocrine guidelines that will be honored for rare tumors of the pituitary and that area with the cancer and endocrine societies. And we've also tried to create, this last is a link to a leaflet that we've created and is posted on our website for charities, trying to just using pictures of the brain that we've developed to try and explain why these children actually have an injury and develop the problems they do, rather than just blaming them on the radiotherapy or the treatment or whatever. So this is histology matters. Histology matters to the oncologist. I think location matters to the injury. And that's quite difficult to get across. So here you can see the amazing improvements that took place before 1999, 2009 in 5-year survival for malignant brain cancers in children. But it was always 95% survival in the lower grade ones. And also you'll see that the majority of tumors in the brain in childhood are low grade. And here are the astrocytomas, but the craniopharyngiomas and the pituitary adenomas are also considered benign. And you'll see that there's a differing incidence. So in children, 10% are pituitary and mainly craniopharyngiomas. In adolescents, 16% are pituitary, and you start to get the malignant germinomas and the pituitary adenomas. They're different. And then the peripheral ones are there as well. So I don't need to remind this audience that the human brain is vital to our functioning, and that but I found it very helpful to produce these diagrams and talk to parents, and also for my own learning, you know, to remind myself of what we learned back at medical school about how to do a neurological examination, right and left-handed dominance, what the right side of the brain does, epilepsy surgery that now takes out a whole half brain if you need to, and you can rehabilitate a child under 7, and also the various parts of the peripheral cortex and what they're responsible for. And if you have a tumor in one of these areas, it seems sensible and reasonable and obvious, actually, that you might have some of the problems that affect. And they've been hugely helpful to look at for parents. You know, well, your child has this problem because this is the area of the brain that controls that on the whole. And it's simplified. And the other thing that I've learned from neuropsychology and working with neuroscience is the importance of the frontal lobe maturation in adolescence, how it's driven by hormone function, sex steroids, that it's not required of us as a function in adolescence. And I say executive function is what no chief executive would be a good chief executive without. So you need planning, organization, judging, behaving, problem solving, decision making. And that matures earlier in the girl than in the boy. which is why girls do a bit better academically earlier on, boys catch up later. But these are all things that I think we need to give as part of our holistic care and information giving when we diagnose a child with a brain tumor, and they're not. And of course, here they are, the tumors on the left and their location. And we've got the ones in the pituitary, and here's the optic pathway, which can extend right through to the optic radiation. Here's the medulloblastomas and the different ones. And of course, if you have something in the vital deep midbrain, but also something that connects, disturbs the connections, look at what that does. You know, blood pressure, heart rate, hunger, sleep, wake, temperature control, reproduction, fight, flight, water balance, stress. And that's happening somewhere higher in higher centers, which is not easy to study. We haven't got an easy way of looking at it. And the hypothalamus, the normal hypothalamus, isn't visible on the scan. So it's been very disturbed and delayed in us trying to work out, but we've had some very interesting studies trying to concentrate on that area. And that's where I've been concentrating the last years of my research, the dark shadow of hypothalamic injury, because I think it really is dark. And hypothalamic disturbance is really awful and potentially devastating. And endocrine physiology matters. So here's the, it's a highly evolved, complex system, which starts in the brain and spreads all around the target glands and is an afferent and efferent pathway, which is time, age, and circumstance dependent. So you don't produce milk for your baby until you've delivered. You don't feel thirsty unless your sodium is high. You don't feel hungry, and that's a bit less good. But you don't, if you miss windows of development, like, you know, potty training and speech and language, it's harder to make them up. And I think we need to think about this more closely, that you don't produce stress cortisol levels unless you have an acute injury. You know, you have a circadian rhythms that you can sleep at night, you get jet lagged. All of these processes that we take for granted are actually vital to life itself. And we shouldn't ignore them. And these diagrams are very helpful in explaining to families what they can expect. And the problem is that injury to this central deep midbrain, which I call the dinosaur brain to the children, because it's the most primitive mechanism that even dinosaurs had to have. And if we're blown off the world again, we'll have to reinvent ourselves that way. The injury is invisible. So a lot of the young people that you saw, like the young girl who was a physician's associate, she actually has complete panhypopituitarism and diabetes insipidus, and is managing a cocktail of drugs through her life. So she needs to be able to do that. She's had a lot of problems with weight regulation, hormone. She's deficient in growth hormone. And she's got some visual impairment because of the hemianopia that the tumor caused. All of these are much more common in children, but they also adapt so well, we forget they're there. What I'm particularly pleased to finally produce, because I was always asked for evidence, and evidence takes many, many, many years to produce, particularly if it isn't funded and you're trying to do it from your own clinical practice. So this is actually the result. I'm very grateful to my PhD students who helped me produce this, and it's the result of the patients that my professor handed over to me, and then I looked over after at Great Ormond Street. And you can see this is a very rare disease, but nevertheless, it's the only study in the world that has 90 children diagnosed with optic pathway gliomas under the age of 3 and followed through 4 decades until maturity. So all of them have been followed for at least 10 years. And we analyzed it by tumor location, how deep towards the hypothalamus they were, age at presentation, and age and time of follow-up, and therapy to try and understand, is it the treatment or is it the disease? And what you find if you do things, because if you do a cross-sectional snapshot, you don't see this, is that a lot of these children start with a so-called diencephalic wasting syndrome, which is emaciation that doesn't respond to feeding and has something to do with the hunger satiety mechanisms. And then 40% of them later become obese. Precocious puberty that then leads to gonadotrophin deficiency. Growth hormone excess and supragrowth, which may contribute to the emaciation, and then growth hormone deficiency. And it suggests that there's something happening in the disturbance of the hypothalamic centers that you will only see if you follow a child longitudinally. And I believe that we will see neurodevelopmental and other cognitive and neurobehavioral changes if we undertake these same studies in parallel. And avoiding radiation hasn't helped. In fact, only 6 children received primary focal radiotherapy, and the rest were treated with primary chemotherapy strategy. And if they failed that, which was 18 months of chemotherapy, they went on to receive up to 6 different trials of chemotherapy. Some of them have had 7 lines of chemotherapy, have never been off chemotherapy virtually, and it interrupts their schooling. And it is not low toxicity the way it's assumed. And we have not been able to rehabilitate them in the background because it's been assumed there is no damage, they're not getting radiation, the tumor's not in the pituitary, and it isn't cured anyway. And you need to be cured before we talk about your quality of life. This is the data which shows you that there's an overall survival which is high initially. But look at this. And this is death, which is termed disease progression, but is likely to be bleeds and late endocrine deaths and suicides. This is progression-free survival, which is appalling. So these tumors keep growing, but there is no randomized study that says treatment does anything better. So these tumors wax and wane naturally. And to use a cancer model which says we give treatment and the tumor stabilizes, therefore treatment must be effective, is a total misnomer to me, because this is not a cancer and they wax and wane anyway. And then we coined this term. In order to show that there was an endocrine deficit, we also produced Kaplan-Meier statistics with which oncologists are familiar, showing that children had a number of endocrine morbidities. So we called this endocrine event-free survival. So you only had to have one, but many of them are multiple, and I'll show you how they evolve. And you can see that they all have a price. This is anterior pituitary dysfunction. So that's the most common, and that's because growth hormone deficiency always comes up trump. So growth hormone is a very vulnerable hormone. Even if you don't see children not growing because you mistakenly, every child with any brain injury has growth hormone deficiency or will develop it given enough time and enough cumulative brain injury. And it's to do with the disturbance of the hypothalamic signaling. A quarter get obesity and type 2 diabetes, which is in itself life-threatening and life-limiting. And a significant number, up to 15%, get life-threatening salt and water imbalance, sometimes acutely and usually around surgery. And that surgery can just be a biopsy. And there's an increasing move to biopsy these children because oncologists need to know. need to know, and to get molecular pathology and so on. So we need to just bear in mind that children die from this. So 2 out of 16 died that were biopsied, and there was salt and water imbalance implicated in their deaths. That won't be on the death certificate, but it's very likely that it was the cause of the death. And these are preventable deaths, in my view, that need to come out. And this is the way that endocrinopathies evolve. So this is a parallel study that we did in all of the children earlier and published using the same analysis. And you can see there's always this hierarchy of deficiency in which growth hormone deficiency is always first if you look for it. And adrenal insufficiency is always the last if you can separate it from when steroids have been used for intracranial pressure from adrenal suppression. And they also have this yin and yang, early puberty, followed by gonadotrophin deficiency. And trying to tease that out in a developing child takes time and care, and you have to ask the right questions. And it's not an easy, and this is diabetes insipidus. And half of them are obese. And this is just to show you that where the tumor is nearer to the deep midbrain, so the more anterior the tumor, the less the problem, the more posterior the tumor. It doesn't have to be in the pituitary to give you this devastating consequence. And that's because the connections are very vulnerable, and particularly the posterior pituitary diabetes insipidus, as it comes across the cribriform base of skull plate, it can knock out base of skull fractures, traumatic brain injury. It can knock out gonadotrophin neurons as well that go, and we've all forgotten that bit of physiology, I expect, and need reminding. And NF1 tends to give a more indolent disease, and indeed all the diencephalics were non-NF1, except one case. So that's interesting. And all of them had deep posterior tumors. And it's the tumor location that codes for the poor outcome. And Darren Hargrave, who is an author on this study, because he has a huge number of these patients, but I hoped it might convince him that we had something to say, and I think he is now convinced. Their vision isn't saved either. And there is an increasing neurobehavioral morbidity. 60% have attention deficit or behavioral problems. 60% need special needs schools or mainstream. And this is for a so-called benign tumor. And it's closely associated with the number of endocrine deficits they get and the progressions, which are not stopped by disease, by treatment, and emerges over time because of the lack of rehabilitation. Radiotherapy always comes out in the multiple regression because it's always used as a salvage factor, as a last resort. And it's a bit unfair because up front, it has twice as much chance of stabilizing disease as any chemotherapy we've had. And yet it's been abandoned. Hopefully with proton beam it might come back. So what have we been doing? Well, this is my endeavor for the last 10 years, which has been a labor of love. And I'm delighted to say that we have finally got an equivalent NICE endorsement against which I hope we can commission care. So this was an endeavor that we had very minimal funding for, but 150 colleagues from across the UK and the world collaborated to produce a consensus and evidence-based management guidelines for these rare diseases in the brain, and particularly the pituitary, which are the first in the world. And they've been commissioned by the Children's Cancer and Leukemia Group, although they're featured on their website. But of course, that's not their main thrust. And I think, and they're partly and they were co-supported by the BSPED, the Endocrine Society, but we really need to get these tumours more into a line with adult pituitary tumours. So these are craniopharyngiomas, just been published at the Lancet, Diabetes and Endocrinology. We've got idiopathic stalk thickening, which might herald an occult germ cell tumor or Langerhans LCH, and pituitary adenomas. And they all absolutely recommend careful surveillance and rehabilitation. And I'm hoping that when they come around to being revised in 5 years, we've actually had a bit of evidence from a registry, because there is no evidence as to whether or not these are working. There is move towards oncologists. This is Professor David Walker's opinion article, which was recently published. And I'm delighted to say that he's also now acknowledging that there's a cumulative brain injury, and that the initial endeavors to predict treatment benefits on survival outcomes or vision outcomes or surgical risk outcomes are not enough. And there are many endeavors: early diagnosis, drug delivery, accelerating surgery. This is a very interesting opinion article. And he absolutely says that brain injury starts with symptom diagnosis at presentation. It's exacerbated by the absence of rehabilitation, and it colors the children's lives for as long as they live. And an important thing I'm also trying to make, as we endeavor to improve the survival of the 20% who are still dying, it applies to everybody, including those who are at the moment not curable, because we're compromising their development, and it should be part and parcel of their cure. So he actually says a strategy that omits the consequence of brain injury is deficient. Overall survival is no longer the right outcome measure, and yet recent oncology papers have not identified brain injury as a target for research. And in terms of commissioning, we have standards that I put in when I was a young doctor from the Children and Young People's Guidance on Cancer from 2005, that you know, they needed rehabilitation, particularly those with brain tumors were a special case. And there was a quality statement, which I'll show you, reiterating that, but they're not fully in place, accepting examples of good practice. And you know, I know that there are good examples of practice in Nottingham, in Cambridge, but it's not universal and it's not mandated, or it should be. We know the National Framework for Children and Young People. Your endeavour, Peter, should be in there, but we keep moving on, creating new goals, and unless we can jump onto the back of one bandwagon, we're in danger of being forgotten.
She spoke to one of the Katies.
There's a rare disease framework. I think some of the pituitary tumours could fall into, and there's also the acquired brain injury strategy that I know was being reviewed. This is what NICE said in 2005: rehabilitation improves outcomes, educational, physical, emotional, essential. I mean, I actually wonder whether we have a legal challenge case. Essential that you should be assessed by a suitably experienced professional. We tend to use neuropsychologists because everyone's been worried about cognition. And that's where all the that's where all the research. But of course, it's much more than that. Multi-agency liaison and skilled neurorehabilitation can make the difference between an independent child and one who needs support lifelong. And even the beginnings of what that rehabilitation team might look like, saying that all disciplines that contribute is not an exhaustive list, endocrinologists in there, neurologists in there, perhaps neurodevelopmental is a separate specialty now. Neuropsychiatry, I think, should be, especially for the deep midbrains. And the quality statement says that children and young people who've had a central nervous system tumor should receive a specialist package of neurorehabilitation, and they're likely to need rehabilitation that's complex for the rest of their lives for some. Commissioners ensure that they commission services. Now, the word should, I'm trying to find should and must apparently are vital here about whether there's a legal challenge. But it does say should include commissioning services with long-term follow-up clinics. Neurological, physical, psychological, and academic function, again, should continue for as long as it's needed. So I believe children with brain tumors are a special case within the group of the acquired brain injury, because if we don't treat them in parallel with their brain tumor treatment, A, it's not a cure, and B, it doesn't feed back into what are the right treatments and what is to be blamed for the poor health outcomes. However, what we know is that at the moment, the brain injury is probably misattributed. Brain tumor survivors have the highest secondary hospitalization rates of all childhood cancer survivors, and endocrinology and psychology, mental health issues are the biggest readmission rates. Most of them can't access rehabilitation or even EHCPs. And I believe every child should. You know, if you're going to treat their brain tumor, you should also treat the inevitable brain tumor injury. And there are 4 stages of development, which I believe we can hang our assessments around and try to see whether each child changes against its own baseline, which has never been done before. But in the same way that I'm allowed to give growth hormone at £6,000 a year to stop a child falling off the 50th to the 25th centile, we should be able to give educational support at £6,000 a year to every child who's on the 50th centile for education to stop them dropping to the 25th. At the moment, they have to wait till they're on the 2nd practically before they get help. And I also think that there's complex psychiatric morbidity that we need help with. I don't think it would cost that much more. The medico-legal negligence budget is now costing the NHS 120 billion a year. It's doubled since they put in NHS resolution. And there's money going in all the wrong places. Benefits cost. If we can get more children independent and employed early, we should be able to save money. And we know from medico-legal negligence case, medico-legal injury claims from traumatic brain injury that these can amount to many millions. And there are several brain tumor children whose parents are resorting to negligence claims for a slight delay in diagnosis because their children have such complex needs that haven't been addressed. You know this, we've said it. I just want to show you what we propose. We propose a second parallel outpatient, non-oncology, rehabilitative, multidisciplinary pathway with a connecting advocate that Success raises funds for initially and trains to undertake that each centre should undertake assessments at these 4 key stages from diagnosis. So immediately you've got a diagnosis of your brain tumour, your surgery has been diagnosed, you're referred to the specialist team for a baseline assessment of your developmental needs. And then you're brought back to monitor, did the recommendations of that package get implemented in the community? How are you doing against it? And maybe funding should come alongside that. And that the teams differ slightly, not much, but each centre, each neuro-oncology centre should, in my view, have a survivorship clinic in which there is this outpatient setting. It should not take from the inpatient setting. The experience is that oncologists lead this. They will take money for care and they don't have time, with all the best will in the world, to do anything else. and increasingly lack the expertise. But that's where brain tumor funding goes, and that's why it's been left out, because it's a Cinderella. And those that are in the deep midbrain require slightly different focuses, but we should at least honor that, because there's more neurodevelopmental and endocrine differs. The others are more neurological and less endocrinology, although they'll all need growth hormone. So this is what we proposed, 2 separate pathways assessed by a neurodevelopmental consultant. So we're suggesting the lead here should be a neurodevelopmentalist, because you bring those services, but that's open for discussion, that there should be an endocrine consultant for the deep midbrain ones and an endocrine nurse for the others, because they have less endocrine injury, and connected by an advocate. And that there will be a full professional team within both, with clinicians. We've included psychiatry and psychology and allied therapists and a review. And this is subject to implementation and review at the 4 key stages, which you've said 0 to 5, 5 to 11, 11 to 16, 16 to 30, which broadly cover education and maturity. And just finally, the other thing we're trying to do is innovate, because that's our other help the NHS innovate. And we've got access to this tele-rehabilitation platform from Israel, which we piloted back in 1920, just before COVID struck and I retired, and is from the Gertner Institute, Tel Aviv, Israel, and has been well developed and proven to work in adults with brain injury, initially from those fighting young people in the war that had brain injuries, but is now rolled out across the Austrian public health system, and potentially is cost efficient, because one therapist can treat 6 at a time, and much more able, because you can do it remotely in your home. At the moment, we tested the cognitive and the cognition aspects of the platform, but there's huge potential. It's remote, it's online, it's delivered into patients' homes or schools or special schools or hospitals. And we believe every child with a brain tumor should have access to this. And we will be the portal for this, which is, we've done the pilot, which I'll show you briefly, but we want to roll this out. And we're actively fundraising for this. So the first 50 children will need £90,000 to do a 3-month trial. Our pilot was a 3-week trial and was on an older platform where we had to send boxes out. But as you can see, it's games-based and virtual, and the child identifies with the parent and child, together with myself and the therapist, who can be remote in Israel, as it was, because we need to train therapists on this platform. And there are chooses a number of different ways in which you can test their ability against 3 goals. So this game is amazing. It's the barbecue. You've got to thread a barbecue, a skewer, and put it on the fire and keep doing it without one burning. So it's processing speed. It's quite clever, and our neuropsychologist Jenny was very interested in it. We also collecting quality of life questionnaires and brief questionnaires. But because COVID hit and scuppered our ability to send out the boxes, which, we learned that all of the 6 children on whom we got full data had parents who were professionals. And we had difficulty getting the disadvantaged children support, despite the fact that I was in the NHS at the time. And I know that from a charity perspective, it's much harder to access children who need it. And I feel we need to access all children, especially those who are particularly disadvantaged immigrant communities whose parents don't know how to advocate. So we really rely on our professionals. And we saw a very good acceptance of the platform, and a very good correlation in the improvements between what the parents were reporting and what the therapists were reporting against the cognition aspects on the left and the motion. Some of them were, you know, I got to stand for 2 minutes they were in wheelchairs or whatever. And there were 1 or 2 discrepancies, but on the whole, there was good agreement and good adherence, because we know adherence matters. And so we have a waiting list of patients, but we would like to work with people to refer in and offer this. We're offering it in we're offering it as a 3-month rolling program in 4-week intervals. So each 4 weeks, patients have to show they're adherent to continue, and we'll be evaluating it. But we need your help. So if we're to stop this little girl who piloted this trial and hugged the developer because she had a brainstem tumor that was operated on urgently to decompress the hydrocephalus in Germany. She then spent 2.5 years in Great Ormond Street receiving surgery and chemotherapy, which rendered her, damaged her left facial palsy and left hemiparesis and her swallowing, needing a tracheostomy. She then spent 2 years having chemotherapy because that's what the protocol said, which caused further infections. 3 times she died. It's very nearly died. Her mother describes it. She is now 10. She's in a mainstream school, 3 years behind, because she's deemed to be of normal intelligence, because the whole aim of this was to avoid radiotherapy. But she's hemiparetic. She's virtually blind. She's completely deaf. They haven't been able to treat her cochlear implants, and that may well be chemotherapy rather than, and she's got a tracheostomy and a swallowing tube in place. So she's speech and language impaired, and she's still incontinent and she received 1 period. I saw her 2.5 years later. I managed to get her a 2-month period in Tadworth, and she's now fighting for the next. And it shouldn't be so difficult. So if you want, I'm going to stop there, but just to say that if you want to support our fundraising, this amazing girl is running not 1 marathon, like the Greek who'd collapsed, but 21 across the Danube in fewer days. She's doing it as we speak, and she's raising money for this platform. So if you help us to spread the word, because we don't have much of a community following at the moment, and can support her, I think she's amazing, and it's wonderful that she's chosen to support us in this way. And I better stop there and hope I haven't run out of time.
Thank you, Helen, very much indeed. And your talk was exceedingly interesting, raised lots of questions. I can see Peter's got a hand up, and we're a little bit over time, but we have got time for questions at the end. But we'll have to get a couple of questions now, because I think people are desperate to say 1 or 2 things before we introduce Tash. Peter, I think you've got a question. Has anybody else got a question on the chat? I can't see. No, there's nothing there at the moment. So Peter, you please go ahead.
So thank you, Helen. That was really, really inspiring. And just to say that I think what you've developed completely separately in terms of conceptualization of a model of care, actually very fortunately is very similar to what the the acquired brain injury neurorehabilitation group have conceptualized. And the difference between the 2012 neurorehabilitation service specification, which is at present on the NHSE website, and the revised service specification, which Anthony is trying to spearhead, taking over from that service spec, is exactly what you talk about. It's outpatient follow-up, long-term follow-up. It's having outpatient and outreach teams that can work with these young people, as well as having standards of inpatient rehabilitation care. So I think if we join forces, which we can talk about outside of this meeting, that will be very powerful.
Yes, I hope. I also, I mean, paradoxically, at Great Ormond Street, we don't have a comprehensive brain injury. And that comes with the Evelina. We refer to the Evelina, and I've had some contact with the Evelina as well about, because I think it's crazy that everything is so specialist. But I think there's we have and we've had neuropsychiatry help too, because I found it very important and very difficult to access neuropsychiatry. And I think there are some drug interventions that could really help these children too, that we need to look at in terms of that.
So the vision of the multidisciplinary team that would be involved not just in inpatient care but in outpatient care and follow-up does include access to neuropsychiatry as well as neuropsychology being a core part of it. You're absolutely right.
I can't see anybody else's hand up at the moment. Tash Cornwall is waiting to speak next. And as I say, we have got some time for questions again at the end of this session. But the world's a bit like, as we say, buses, and things come along when you're waiting for a bus, then two come along together. And of course, Helen's Success Charity has grown in the last 3 years. At the same time as the Tash Cornwall is going to be talking about the Tessa Jowell mission. And Tash is the manager for that initiative, and Tash will tell us about that and the relevance to children and children requiring neurorehabilitation in a moment. So thank you all. Tash, if you are running over more than a few minutes, I'll just put my finger up. But please go ahead, and we're delighted to welcome you. Thank you for agreeing to speak to us.
Thank you. Thanks, Jane. Thanks for having me today. I'm just going to pull up my screen to just let me know if you can see the slideshow, okay?
Mm-hmm.
Great. Perfect. So yeah, my name's Tash. I'm the Children's Programme Manager at the Tessa Jowell Brain Cancer Mission, and we've launched our Centre of Excellence designation programme for children. So I'm just going to tell you a little bit about that today, about the mission, kind of why we were set up, and a little bit about the adult programme and kind of how it's led to the children's work we're doing now. So I'm sure you all heard of Dame Tessa Jowell. She was a Labour MP who was unfortunately diagnosed with a brain tumour over 5 years ago. And she advocated for change in her last campaign, where she realised that not all patients across the country had the same opportunities for care and research. And so the Tessa Jowell Brain Cancer Mission was formed as a convening body. We're a not-for-profit company with just 6 full-time employees, and we're funded by Department of Health and Social Care and some national cancer charities. And the Tessa Jowell Foundation is also one of our funders, who was set up in Tessa's name by her daughter Jess. So all of our programmes are entirely dedicated to brain tumours. We have 8 innovative programmes. We work on research, advancing precision medicine, clinical trial infrastructure, training NHS staff, and elevating care for today's patients, which are our Centre of Excellence programme. So I'd love to tell you about all of these. There's more information on our website, but obviously today I'm just going to focus on our Centre of Excellence programme, starting with the adults. So our Centre of Excellence programme aims to incentivise and support neuro-oncology centres to jointly tackle national variation in treatment, care and research for patients with brain tumours. And together with the experts in the field, we set standards of excellence which define what excellence in brain tumour treatment looks like, and kind of designed an extensive application process to assess the centres against these standards. So yeah, these are just some of the pictures of our centres that were awarded excellent status a couple of years ago. So the adult process started in 2021, and we're just about to relaunch next year, our next round. So it's kind of a 3-year process that centres are invited to apply to. So because it was our first programme, we really wanted just to understand the current care of patients with brain tumours across the UK and what variation exists, and identifying equality to then help address the gaps. So in the adult process, there were 28 centres that applied to be assessed. They had application forms, over 100 questions, and explored every part of the brain cancer service from diagnosis to end of life care. The application forms, together with patient feedbacks, are reviewed by centres, reviewed by committee of experts, and then invited to a 2-hour interview where we explore their centre in more detail. And this process really allowed us to collect a large amount of data to create a national benchmarking data set on brain tumour care in the UK. And we are able to report back to the centres and how they perform in comparison with their peers, and give detailed feedback on their areas of excellence. And in total, 17 centres are now a designated Tessa Centre of Excellence for brain tumour care. So armed with all this information from the application process, our committee assessed each centre against our standards of excellence, and centres are designated if they met the standards in all the areas. And it's just worth noting that our standards of excellence are very kind of high and ambitious. So if a centre is meeting a standard, it's already really impressive, because they're already doing some really work. So through this process, we had 3 categories of centres. So designated centres met all the standards, and they were able to share best practice nationally. We encouraged them to kind of share the areas where they're doing some excellent work. And then the centres that had gaps or areas of improvement were provided with bespoke support from our committee and from our kind of team, and to really raise their service in areas that might have gaps. So every centre that applied did have pockets of excellence and innovation that was really worth sharing nationally. So the centres that were awarded Centre of Excellence all had kind of 5 key aspects that kind of was common across them all. So they all had a kind of a key staff member who went above and beyond for their patients and was really driving innovation and service development. They all had excellent relationships with their trust and their management team, who are really supportive of their efforts to grow as a service rather than just to maintain at the current level. They showed seamless integration, demonstrating strong links with colleagues in district general hospitals as well as community teams. And centres also showed strong clinical research by running clinical trials or having good referral pathways to access trials. And all centres, regardless of their kind of status and outcome, were all demonstrating this kindness, compassion through patient-centred care, which was really amazing to see. So there were a number of areas that we identified that would require some additional support. So there was 3 categories, and kind of obviously we know about NHS workforce struggles, and then quality of life care and research. And we use all this information to provide kind of anonymous updates to the government via Department of Health and Social Care and NHS Cancer Commissioning leadership teams, because they are really motivated to understand what the current gaps are, and using this data they could kind of go away and think about how to mobilise more funding and supporting kind of working groups to really support the service development of the brain tumour services in the country. And so in the centres that were not initially designated but then invited to reapply the following year, and then were designated as excellence after that, they really benefited from kind of their support offered from the committee of experts. And so really looking at the rehabilitation, for example, one centre was able to take a business case to their trust using the benchmarking data, and got funding for a dedicated outpatient physio, and expanded their inpatient rehab services. So these are just kind of a small snippet of examples of all the amazing work that some of the centres went about and did to address their services and kind of improve any gaps that are identified. And so looking at a little bit more about rehabilitation data. So in the adults centres, there basically was kind of these 6 key areas that were showing for examples of best practice. So the areas were specialist rehab assessments in AHP dedicated led clinics, and they were assessing their patients before, during and after treatment. They had screening tools that identified the patients throughout the journey. The AHPs were really highly trained and specialised in brain tumour care, and had a lot of opportunities to engage in research and through peer learning. There was strong links with community in these centres and the community AHP teams, and some of these centres are also able to offer rehab programmes for outpatients and within the community. So as this was the first programme, it really informed a lot of the work that we do today. So as well as supporting all the centres through one-to-one support and providing benchmarking data and case studies for best practice sharing, we also set up an online academy platform to share best practice and support the gaps. So we, I'll tell you a bit about that in a few more slides, but we'll just go down to the bottom. It's a national challenge project. So one of the really interesting things we found from the adult data is it kind of genomics is really variable across the country, depending on where you get your treatment, depends on when you can have access to genomic testing. So we're kind of looking at uncovering that in a bit more detail. And we've got an equity and genomics task force to really understand what's going on, what are the key barriers to getting genomic testing, and kind of how we can address these. So our Academy platform is an online platform for all NHS staff working in brain tumour care, and it's really designed to address the gaps that we identified through this process and also share the excellence that we also identified. So it's got some really amazing features. We've got 7 national networks and 8 working groups, and it's really popular with AHP. So we've got a lot of physios, OTs and speech and language therapists on these working groups, and they kind of lead all the workshops, training days, they lead all this peer training. So we've had loads of really interesting training recently. We've got a fundamentals in neuro-oncology for anyone kind of new in the field that wants to understand a bit more about it. We've got AHP Spotlight series to kind of like understand a little bit more about what each AHP does and kind of how they have their rehabilitation pathway in each centre. Supportive care course was really popular. And then we've got a peer-to-peer connect, which is kind of like our Tinder service for healthcare workers, where if anyone wants to kind of learn a bit more about a particular service, they can reach out to someone from a different centre or from a different hospital and kind of understand a bit more about their work. And then we host lots of resources, and we've also got a clinical trial finder on there as well. So using all this information, we obviously did really enjoyed the process, and it was really popular, and we got a lot of requests to do the same thing in children. So we set out about 2 years ago to start planning the Centre of Excellence for Children, and it's launched this year. So it's led by Dr. Stephen Lewis, who is a retired paediatric oncologist from Bristol. And we have a committee of 26 experts who are all active in paediatric brain tumour care or research. And the aim of the programme is to really improve brain tumour treatment and research for children, starting with an in-depth review of the current services and followed by the recognition of excellence to kind of really showcase the amazing work that's currently going on. And all centres across the UK have been invited to apply, and they were invited over the summer. So before we did launch this programme, we worked with our expert committee to create 3 key publications. So we have an evidence base, which is a comprehensive overview of the current challenges in paediatric brain tumour care, research and treatment. We have then standards of excellence. So the evidence base informs kind of what's currently the baseline kind of care and where we want to raise the standard. So we created our tested our standards of excellence using this to really kind of look at the future ambitions for excellence in care and research. And then using the standards, we then have an application form. So each standard of excellence is tested in the application form. And there's over 170 questions that I'm sure any of you who were involved in the application process, it was a lot to kind of uncover. So it was really the whole patient journey. We're looking at from diagnosis all the way to end of life or rehabilitation and late effects and aftercare. And centres were also invited to complete a feedback survey from the Brain Tumour Charity as well to gather the patient data alongside this. So within our evidence base, we worked with the rehab experts to kind of uncover what's going on in rehabilitation for children with brain tumour. And you know better than everyone that children with brain tumours have considerable rehabilitation needs due to the impact of the tumour itself and the therapies to treat it. And so early intervention and subsequent long-term support is really needed. But despite knowing this, a lot of centres really struggle to provide comprehensive rehab services. And so our experts really highlighted there's quite a lot of room for improvement. In many centres, there's a shortfall of dedicated rehab service and community. It's particularly notable for cognitive rehab and speech and language services. More generally, many centres struggle to obtain timely appointments for their patients once they're referred, with community services often having the longest wait list and they're overburdened. So yeah, so children obviously not always getting appropriate rehabilitation needs after having acquired brain injuries. And so our standards of excellence are based on current models, of course, Brainbow and Brill, and their kind of expertise, but it's not kind of based on the specific way that they work. It's really to demonstrate that every centre needs kind of these clear standards, such as a referral pathway to provide the robust, timely referrals. Every patient should be assigned a key worker so they can have key kind of assessments at key time points, and the key worker can proactively identify these needs. We suggested that centres communicate well with all the team members and patients and families, as well as communicating with the community, and ensuring the kind of good access and continuity of care was really key. So obviously then based on this application, the standards, we then develop the application form. So it's really looking at uncovering kind of what the current service setup is for rehabilitation, kind of what the training each staff member has, if they feel like the rehabilitation needs are met, kind of how the assessments go about. So there's a long list of kind of questions that we've asked the centres to respond to. So we're currently in the process, we're analysing all the data that we've gathered. So all the centres sent in the application forms in July. Our experts are doing a really detailed review. We've got 26 experts in total. So kind of all the application forms go through quite a good cycle of review to make sure that it's quite a fair and robust process. In October, we're meeting with the committee to discuss the applications in detail, and then centres receive an individual feedback report once we've kind of finalised the peer review day. And then centres are then invited to a virtual site visit where we have kind of a 2-hour discussion, a bit more about their application and anything that we kind of feel like we didn't understand fully from the application form. And then at the end of this year, we'll be kind of announcing the outcome, and every single centre that applied is invited to join the Teshajal Academy, which will then kind of develop more children's material on. So I want to emphasise here that this programme is quite long term. So obviously we've been around for 5 years and we're kind of only just getting started really, but we are solely dedicated to brain tumours, and our aim is to create an ecosystem of support informed by the data we're capturing through this designation process. And with each unmet need identified through the process, we're going to try and build tailored solutions, and we want to be a really paediatric focused academy of the arm to kind of address any challenges and work through these solutions. And together with our partners such as CCLG, patient charities, and like the BPNG as well, we will provide tailored education and networking opportunities for kind of all staff that are working in this field. So just to keep in mind, as we continue on this initiative, we're kind of here to help all of you, the NHS staff working in this field, and to build solutions that might help you to deliver the best possible care that you can for your patients. So really, anytime you're getting frustrated or struggling or having the same problems over and over again in the workplace, just we kind of would love to know so we can help address them and kind of use our contacts and network to really support any challenges and currently in rehabilitation for children with brain tumours. I think that's almost the end. So yeah, it's been a really really good process so far. Met with a lot of engagement, a lot of applicants, and obviously we've got Success Charity here with Helen. So a lot of charities are really keen, obviously, to get involved and kind of use the work that we're doing to kind of build on their work, and it's a really nice kind of collaborative process where we can kind of just all work together to really do what we want to all achieve, is helping these patients have the best outcome possible. So as I said, please do let us know if there's anything you want to let the Teshajal Brain Cancer Mission know, and obviously we can do what we can with what we've got and try and really help out as much as we can. So I think that was in my time, Jane. Tried to rattle through. But yeah, thank you very much for listening.
Perfect, Tash. Thank you. Well, very exciting process, and as I said, we had questions at the end, but if anybody has their hand up for a question now, I'll happily take one. Other than that, we can move to Shona's presentation.
Jane, I'm sorry I keep asking questions, but that was excellent, Tash, and really interesting. Can I just ask, you mentioned the group of experts, and obviously you mentioned Steve Lois. What sort of professional backgrounds do the other experts have, and how many of them are there?
Yeah, there's 26 experts, and we have a huge range. So we've got a few oncologists, consultants, we've got physiotherapists, we've got play specialists, we've got a clinical oncologist, a radiographer, surgeon. So essentially, I think we've tried to get a whole range from across the whole patient pathway.
Have you got any neurologists or neurodisability consultants with an interest in neurorehabilitation? Because I think, you know, given that I know it's only a part of what you're doing, but given that you've identified an important area is to provide rehabilitation services, I think they might add something to what you're doing going forward.
Yeah, that's a really good idea to include. We haven't currently got a consultant. We do have consultants from the Brill and the Rainbow teams, so they've kind of got their experience. But yeah, we haven't got a kind of a consultant with a special interest in neurorehabilitation.
If I can come, yes, Rachel Keatley, one of the special interest group members. I think Rachel's on the call. Whose background is paediatric physiotherapy and neurorehabilitation and general paediatric physiotherapy as well. Rachel, do you want to say anything about that?
I was just going to say Amos is on from Rainbow. I know Anna's just asked. Amos is on the committee too. So yeah, so Amos brings some paediatrics background into that neuro rehab section too.
Amos's background is neuropsychology, is it?
He's a paediatric oncologist.
Pediatric oncologist.
Listening to Helen's talk and this parallel pathway that we're hearing about, which we have talked about a lot in the neurorehabilitation, early intervention of rehab alongside acute care, and Helen's pathway, recovery pathway, referring to a similar model. Perhaps Peter's point, Tash, will be something you can take back to the Tessa Jowl team.
Yeah.
But now we're going to hear from Shona, who is a specialist nurse in acquired brain injury with a long experience in Southampton. And she will be sharing with us how Southampton's model for neurorehabilitation for their patients, including brain tumour, is in practice. Thank you, Shona. And do store up your questions for the end of the session before our comfort break. Thank you, Shona.
Thank you for asking me to talk. Can you see my slides? Just because I'm hopeless at sharing. Yeah, perfect. So I'm going to cover how we have aimed to incorporate neuro-oncology rehab into our neuro rehab service that we have in Southampton, which is kind of addressing some of the issues that the first two presentations have covered. So our neuro-oncology rehab service is called Robbie's Rehab. Oh no. I can't move my slides on. I failed at the first. Oh, there we go. So just as the background for anyone who doesn't know, Southampton is at the bottom of the UK. We cover the south of England. We're a children's hospital within a combined hospital. So it's adults and children's all in the one hospital. So we're a virtual children's hospital rather than a standalone children's hospital, but we are the regional centre for specialist paediatric care. So for neuro-oncology, we have neurology, neurosurgery, oncology all on site, and we also have a PICU on site. Our radiotherapy is done in London, so that's the only part of the neuro-oncology care pathway which is not with us. Our neurorehabilitation comes under paediatric neurology, and it's always been part of paediatric neurology. I came to Southampton in 1994, at which point there were two paediatric neurologists. There was a physio, an OT, and a speech therapist, and some limited neuropsychology. And patients with acquired brain injury received inpatient neuro rehab as part of their inpatient stay and their care pathway. For those that were severely impaired or were going to have long-term rehab needs, we did use the Children's Trust at Tadworth and also Chailey Heritage, but primarily we were rehabbing patients as inpatients. We didn't have a dietitian for our service, we didn't have an outpatient service, and we had no named beds for rehab. So patients were admitted under paediatric neurology, but they weren't in a designated rehab bed. And looking back at all of our data, we've always had about 30 or so patients a year, and there's on average about 6 patients in at any one point having rehab, and their length of stay varies, but on average they're having at least 4 weeks rehab. So we had all this good rehab going on. We weren't formally recognised as a rehab service, although we were delivering excellent rehab, and we, like lots of people, had insufficient space and equipment, and we could always do with more staff. So we set about in 2011 to do a business case looking to get additional funding for our rehab team. We were using the major trauma as a kind of lever, because we were about to become a major trauma centre in 2012, and as part of the major trauma you obviously need to have some rehab running alongside all the kind of life-saving stuff, and we figured that potentially we would get more severely impaired children and young people coming through, given that we were particularly a combined adults and children's hospital and would for major trauma. So we may have more patients requiring neuro rehab, and therefore our service would not be able to meet the need. So we put together a business case asking for quite a lot of stuff, and then continued to negotiate over the next sort of 3 years with both our local commissioners and also with NHS England, looking at how could we get some additional money to continue to support our rehab service. In 2015, NHS England gave us a block of money to deliver intensive acute neuro rehab for 4 designated beds. So we comply with all of the kind of NHS England standards for neuro rehab. So we're registered with UK ROC, submitting our outcomes to the rehabilitation network. We function effectively as a level 2A centre. So when level 1 is the highly specialised, we are effectively 1 step below, but that does mean that we still treat highly dependent patients. We do in-reach into PICU, for example, and we can deliver inpatient neuro rehab. So our 4 beds weren't extra beds to our trust. They were part of the beds we were already using, so it didn't come with any nursing support, but we had additional money that we used to build further onto our rehab service. So in psychology, we got some additional money for 2 part-time staff who make 1 whole-time equivalent, and a bit of additional senior psychology support. In therapies, we got some physio and occupational therapy time, speech and language therapy, dietetics, and then we also had some money for nursing, and we chose to put that into play specialist and youth work. So what does our pathway kind of look like? So we called ourselves the SCIRT team, which is the Southampton Children's Integrated Rehab Team. And one of the reasons that we have the integrated in there is because actually we're delivering our rehab alongside whatever else is happening. So rehab doesn't come at the end or doesn't come to the exclusion of everything else. You can have rehab whilst other stuff is going on, hence the fact we're integrated. So patients who are in our SCIRT service have an inpatient rehab pathway. They have a daily timetable. They see each of the disciplines that need to be seen. So physio, OT, speech therapy, psychology, specialist nursing support. They'll have school via our hospital school at whatever point they're able to access some school, whether that's bedside teaching or going into our classroom. And we run a modified 7-day-a-week program. So patients who are in at the weekend, and particularly in the early phase of their rehab, will receive rehabilitation on a Saturday and Sunday from physio and OT for half the day. So they'll have a morning session of physio and a morning session of OT. We do encourage weekend leave as soon as the patients are well enough, in which case they don't have our weekend service. Following on from that, patients can access our transition service, which is an outpatient arm to our inpatient service. And that's for patients in order to get home faster. There may be a gap before community services could pick them up, in which case they can come back and have sessions as an outpatient, or it may be that the community can only offer 1 session a week and we feel they'd benefit from 2 sessions. Then they can come back and have 1 session with us, 1 session in the community. And usually this would run between 1 and 2 sessions for each of the disciplines per week over about 4 to 6 weeks. Crucially, that service is only available if you've been on part of our inpatient. So you can't access the outpatient transition service without having been through the SCIRT service. And then for all our patients, we liaise with their community. So the community services obviously differ throughout our region, but we aim to get all our patients linked in with their community services as early as possible so that they can start to pick up receiving community therapy as soon as they're discharged. So where does the brain tumours fit in? As has already been said, the rehabilitation needs for brain tumours can be sort of anywhere within their pathway. So our brain tumour patients, when they are here in the surgery element and immediately after surgery, can access our SCIRT rehabilitation. And in fact, many of them do. They will receive input in the early phase if they're not going on to have any additional treatment such as radiotherapy or chemotherapy, so one of the low-grade tumours, then they would stay with us and have their rehabilitation with us and then follow our normal SCIRT pathway. If the patients are having radiotherapy, unfortunately they are off site, so we can't influence their rehabilitation whilst they're off site for their radiotherapy. But those who are having chemotherapy, if they still have high rehabilitation needs and we would otherwise have kept them in to be part of our SCIRT program, we will give them a modified rehabilitation program while they're having chemotherapy. So instead of twice a day input from some of the therapists, we may drop it down to once a day, or may miss a few days when they're feeling particularly unwell from their chemotherapy. But essentially, we would aim to keep their rehabilitation going while they're on chemotherapy. For patients when they come to end of treatment, if they've still got significant rehabilitation needs, we would do an elective admission to come back in under SCIRT, to then have 2 weeks of intensive rehab to see if we can push on any of their kind of progress in that week. And then obviously they go through into community the same as the rest of our patients. So where does Robbie come into all of this? This is Robbie. He was an 8-year-old who was treated at our centre at the age of 8 with a standard risk medulloblastoma. He had all of his treatment and was actually very well during his treatment. This is his family. Oops. They decided that they wanted a challenge while he was on treatment, and so they did a rally car race, raised a load of money and decorated the playroom and schoolroom, and then got the bug for fundraising and decided that they would continue to raise money with the aim of supporting children and young people with a brain tumour, and so came to us to ask what else we needed other than decorating rooms, and so agreed to be part of our Robbie's rehab program. Sadly, Robbie relapsed and then passed away, but his family have continued to want to be involved with fundraising and supporting Robbie's rehab. So what did we do? We looked at could we make a rehab service that would fill the gaps. So we knew that what we were delivering was good. but you had to be in the right place to receive the rehab from our team, and actually you couldn't keep being readmitted for intensive rehab. So was there a way that we could build a service that would fill in any of those gaps? So we made a proposal in 2015 looking to see, could we have a separate service for neuro-oncology that had physio, OT, psychology and speech therapy in it. That's obviously was quite a big ask, quite a lot of money. So we refined that proposal and decided that we would do a 3-year plan where we would collect data prospectively, and we would look to sort of prime the trust for picking up the funding at the end of year 4. So we started with physio with the aim that physio would look in that first year how many patients who were effectively outpatients or not accessing the rehabilitation that they needed, would we be able to draw in to Robbie's rehab? And at the end of the year, we found that there were quite a lot of patients who weren't officially receiving rehab that would benefit. And so then we rolled over into year 2 and year 3 with physio and psychology. So our physio is 0.6, so 3 days a week, seeing on average about 30 patients a year, doing perhaps kind of what is relatively standard. So seeing our patients while they're an inpatient. So any of the patients coming in and out for chemotherapy are often never in the right place to have community therapy. And so they keep missing out on rehab. So by her being based here, she's able to catch up with them when they come in for their chemotherapy, able to provide a burst of rehab with an identified goal. So very clear that there needed to be both a patient-focused goal and a goal that we felt was realistic, and looking to provide a burst of rehab at those times of transition. Also looking to do early discharge with bridging the gap for community therapy. One difference from our kind of skirt transition was looking to see, actually, was there the option to support patients back at in their local area. So a couple of patients wanted to be able to use local leisure facilities, and so the physio went out to the local leisure facility and worked with them in their therapy sessions within the in the local area. Also looking at pre and post-op assessments, not excluding our palliative group. So some of the patients coming in with brainstem tumors, for example, who were clearly going to have complex needs evolving, we didn't exclude them from rehab, and the physio was key in helping to set up the support to get those patients home, sourcing equipment and that sort of thing. Also been involved in looking at patients with disease progression or a change in their symptoms and doing referrals onward and signposting. Psychology, with 2 parts to psychology, a clinical psychologist half-time and a psychology assistant. So they started in May 2018 and have it seeing about 50 patients a year. They provide additional support to the psychology support that's already available. So support for the child or family, also looking at things like interventions for low mood and anxiety and sort of post-trauma work. They also work with our parents, looking at how to help support the parents and the child through things like procedural anxiety and any behavioural problems which are emerging. A lot of our young people, particularly those who've had their tumour when they were quite young, as they're getting older, helping them to do a story of their journey through hospital and correcting some of those memories that they've got about what treatment they had, what happened and in what order, so that they're better informed as they go forward to be able to retell their story for when they start college or university or moving into the field of work. All of our kind of rehabilitation goals are supported by psychology. So we're looking with the psychologists at kind of well-being and quality of life. Neuropsychology is also looking at doing the neurocognitive assessments. So we already had a neurocognitive assessment waiting list, which covered our neuro rehab patients. And then this was making a separate list for neuro-oncology patients so that we could be more reactive and faster to get to assessments rather than sitting on a waiting list where there might be a need. So having gathered all that data and shown that actually there was value in having this additional part to our service, we were then looking at how could we keep this going, either with funding coming directly from Southampton Hospital as a trust, either coming from community funding or charity funding. There's obviously a lot of pros and cons of all of those things. Our preference was to have the funding coming from the trust so that we would have Robbie's Rehab service as part of our SCIRT service. That way the therapists themselves gain peer support. There's also they get educational support from their the rehab team. They can be part of any in-house training and education that's going on. It also means they've got the opportunity to phone a friend if they need some advice, because there'll be somebody nearby that they would be able to ask advice of. And also we've then got some cross cover for sickness and maternity. And because we already had the transition element in our SCIRT rehab service, we felt that the Robbie's Rehab actually fits quite neatly into that transition, because it covers the same sort of ethos of transition. We're aiming to reduce length of stay, we're aiming to improve the quality of survival, and we're filling in the gaps in the existing rehab services, and particularly supporting the community rehab and that transition into adult services. So where are we now? So from April 2021, the Robbie's Rehab is now part of SCIRT. The charity paid an extra, we got agreement that it would transfer over in 2020, but because of COVID, our charity partners, Robbie's Rehab, very kindly agreed to pay an extra year of staff costs whilst COVID was at its peak. But it's now fully funded by the trust. And so how we manage it is all our new neuro-oncology patients see psychology and physio as part of their admission. They're all offered follow-up with the Robbie's Rehab team. So that comes as a appointment to attend our MDT clinic at end of treatment. So for patients who only have surgery or who are diagnosed and only have biopsy and then go on to surveillance, they'll be offered an appointment within the first couple of months after their diagnosis. And for any who are on treatment, chemotherapy or radiotherapy, they will be offered an appointment when they get to end of treatment, but they can be referred into elements of the service throughout their journey. We just make the clinic quite a bit more of a formal marker for end of treatment. And the clinic is a non-medical clinic, so it has a nurse specialist, a physio and psychology at it, kind of going through where is the child and the family up to and what areas, if any, do they need support in, and then we plug them into the relevant support or offer the support as needed. We've started a quarterly MDT clinic for transition, so thinking about moving on to adult services. And in that clinic, we include the late effects nurse for oncology, who looks at the Ready, Steady, Go program and helping to support the young people as they move from the very pediatric clinic into the young adult clinic. We continue to collect data. We're obsessed with data. That's the one thing that everybody needs to be collecting. And so each year we produce our annual report for our SCIRT team, and the Robbie's Rehab team has their data collection goes into that report. Next thing that we're going to do with the Robbie's Rehab fundraising team, who are continuing to fundraise, is to build a designated rehab ward space within our children's unit. So we will actually have a cohorted space for our for neuro rehab, and so some of our neuro-oncology children will receive their rehabilitation in a neuro rehab space as opposed to just within our hospital. We have a criteria for referral, which is quite broad. Basically, the child and young person just has to have either a brain or a spinal tumour, and they have to be under the care of the Southampton Paediatric Neuro-Oncology team. That's kind of our only kind of entry criteria. We're aiming to add to what's already being provided. So we're not intending to replace anything that already exists. So any community therapy services that the child might otherwise be eligible for, we would still refer the child into those services. Robbie's adds in an extra bit, either something that's missing or a top up for what they're already receiving. We aim that they can access the support at any stage in their pathway. So they might have received treatment at the age of 5, and then they might have no perceived rehab needs until they're 15 and thinking about moving into adult services, at which point they could come back and access the Robbie's service at that point. So although they would be eligible for the service throughout their entire until they move on to adult services, they wouldn't necessarily be being seen by the rehab team every week in that time period. Each time that they're seen by members of the team, it would be for an individualized specific piece of work that would be done with a goal. When they've reached their goal, then they would be discharged from that period of intervention, and then they can come back again. This is our team. So we have Leonora's the nurse specialist, Pippa does our admin, Kirsty's the clinical psychologist, Kate does our physio. She's the only member of the team who's been there right from the start. And then Sharon at the end is our psychology assistant. We collect, as part of our data collection, we collect feedback from the families as to what they've felt the benefit of the service has been. And this is just a collection of quotes from the families. I'm not going to read them out, but we collect that as well as and outcomes as to whether or not they have achieved the goal that was set at the start of their rehab. That's it. Very quick.
Thank you, Shona. Excellent. So you were describing an admirable service. I'm open the floor to questions before our comfort break. Thank you. So Sarah, please introduce yourself and where you work, and then ask the question. Sarah Abernethy.
Hi there. Thank you so much, Shona. I'm Sarah Abernethy. I'm one of the paediatric neurologists in Glasgow. I was listening to this with great interest because I think your service pre-Robbie's rehab sounds very much where our service is at the moment. Did I correctly pick up that by the time you actively started looking for the neuro-oncology group, that actually what you more than doubled your numbers coming through your rehab service? Is that right?
Our inpatient service numbers have been relatively static. And our neuro-oncology numbers, we anticipated the kind of annual number of patients who would be seen would be effectively static, although more patients would be added to the overall total, if that makes sense, because of the fact that patients would have a time-limited intervention. So they would be like effectively a rolling number of patients being seen, but the overall number would increase because we would continue long-term follow-up. But our inpatient cohort has been more or less static, I think.
Okay, that's very helpful. I think our numbers are quite similar looking at your data, so that's been really helpful. Thank you.
Thank you, Sarah. Better.
Shona, that was lovely, and it's clearly a very well integrated service. But you mentioned that when patients have radiotherapy, I think you said they go to London, didn't you? What happens?
Yes.
Do they get some rehab in London, or do you admit them when they finish their radiotherapy for the short burst of intensive rehab you were talking about?
Yes, so we liaise with the team in London. They go to UCLH, so there isn't a rehab service that they then slot into, although they do get some access to some therapy, but not at the same intensity or complexity that they get from us. And yes, we would, at the end of their radiotherapy, if there's then a gap before the next bit of treatment starts and they would otherwise go home to recover before coming back for chemotherapy, we will do an elective admission at that point back under the SCIRT team intensive rehab.
And do you sort of warn parents about that sort of before they go off to London? Because in my experience, unless one does that, sometimes parents just want to go home because they, you know, it's early on in the course of the disease, and they don't always quite get why rehab matters at that stage.
Yeah, I mean, it has, because of personality, it has varying effects. So for some families, having been in London with less rehab, they just want to get home because actually they feel they've done a lot of sitting around, and you know, they've been even further away from home than being in Southampton. So the thought of then having another period in hospital, they want to go home. We do tell the families that the rehab in London will be less than with us, but I think that doesn't really mean anything until the families have been in London, because there's so much that they're having to think about at that time, that rehab is quite low down on, unfortunately, the oncologist list, so it's therefore quite low down on the parents list, whereas we're saying actually this is really important and we want to do this, but the oncologists are talking about, well, you've got to get this treatment in. And so I think there is a bit of a mismatch between what we're trying to say to the families is important and what the oncologists are saying. And so for some families, they will side with the oncologist and say, well, the oncologist says we can go home, so therefore we want to go home, rather than saying, oh, you're recommending that we stay for some additional rehab. And we do have, for some of our families, quite a lot of push back on there, well, why can't we come and see you daily for outpatient therapy? And actually most of these children are shattered. So the real reason they can't come and see us for outpatient treatment is they're too tired.
Yeah.
And actually they need to be getting good sleep. They need to be with us to be able to have good rest in between sessions to actually benefit from their rehab. But again, that's quite difficult sometimes to get parents to really understand that they need to not be tired to have rehab.
And have you found that having multidisciplinary, I mean, are your oncologists willing to come to multidisciplinary meetings around the rehab aspects of care? Because that's an opportunity, if they are, and I don't know, to pull things together a bit.
Yeah, and again, that varies. So if we have a patient in who's got lots of rehab needs and they're about to start their oncology treatment, then we do invite, as well as the neurologist, who's Georgie, who's just turned her camera on. She will be there as the neurology consultant lead for the MDT, and we do invite the oncologists. I have to say our oncologists are great and they will say very positive things about rehab. But actually, if it came to, can you do this rehab over this bit of oncology treatment, they will always prioritize their oncology treatment. So they inadvertently downgrade rehab. And they will often say to families, this child doesn't need to be in, they can go home. We've told them they can go home. And then we're kind of running along behind trying to say, actually, no, we wanted you to stay.
It's difficult, isn't it?
Yeah.
Thank you, Shona, and thank you for highlighting the fatigue this group of children will manifest, which is a real problem that they express themselves. But I think Helen's given us a question on the chat about the responsible lead. Helen, do you want to share your question? And perhaps Shona and Georgie can reply.
I'm kind of thinking, and also thinking about the Tessa Jowl spec and the experts. I wanted to ask the Tessa Jowl, as well as neurodevelopmentalists, are there psychiatrists and are there endocrinologists, and as well as neuropsychologists? Because people tend to think of late effects as being purely neuropsychological or psychological. I think there's a lot of other, and also to think of rehabilitation as being purely neurological, and yet it's quite clear from the guidance that it should be much more comprehensive than that, and from the evidence that there are other multi-specialist needs. And I would be in favour, I don't know what you think about that, but one of the biggest problems for me anyway at Great Ormond Street was trying to decide, well, who am I going to actually actually get the funding for, because the endocrinologists weren't interested. They, you know, it's not their patch. The neurologists weren't involved. They were added on. And the oncologists were too busy. But if you gave funding to the oncologists, it would tend to be pulled into acute care. So I'm interested, and I think what you've said, Shona and Georgie, is that yours is a separate neuro service. But I'm just wondering whether, if you were to create this ideal MDT, it's not the oncologists you want, it's the endocrinologists and the other rehabilitation psychiatrists, because I go to a lot of acute MDTs, which I'm not funded for, to try and just identify which children really need the rehab support, to try and pull them out, and which really need pediatric endocrine decision-making care. That's why I was proposing 2 separate pathways. But they're not properly funded. And as you say, the tension of the one, and I think there's an argument to say that a cooler, calmer rehab MDT, which is funded through neurodevelopment or neurorehab and includes other professionals alongside it, including endocrinology, would be a much better option. And it is for the patients too, because they'd come and see a comprehensive clinic.
So, Helen, that is the model that operates in Southampton from Georgie answering on the chat, and you know, does pull in endocrinologists as well for some of the oncology patients. It's also the model that we have in Bristol at King's College Hospital, in Nottingham, in Oxford. So there are certain services within the UK, neuro rehab services, that are commissioned and are funded, and then there are the vast majority of whom Great Ormond Street is one, who are not. And Great Ormond Street is slightly unusual because most of the other unfunded centres, for example Liverpool and Birmingham, are nevertheless trying to deliver a service on a similar model. Great Ormond Street haven't got the beds, and although there have been, from talking to their neuroscience lead Prab Prabhakar, there have been some attempts to sort of set something up. They've all fallen by the wayside because there's a lack of, as I understand it, there's a lack of support for management because of worry about the bed implications. So I think you're particularly unlucky at GOS in that there aren't neurologists who've got the appetite to get involved. I don't think that's, you know, true in quite the same way elsewhere.
I mean, I think in Southampton, we don't have a clinic that has every single one of those people in it at the same time. But certainly for neuro-oncology, I think the addition of our Robbie's clinic, which is a non-medical clinic, is actually very successful for families, because the emphasis then is not on when is your next scan, although obviously that does come up because there's obviously things like scan anxiety and relapse anxiety is kind of present for a lot of our families. But we are focusing on what are you doing? Are you at school? Who are your friends? What social things are you going up to? What's your fatigue like? And so occasionally we will pick up in that clinic somebody who it wasn't apparent from their tumor or their treatment that you would have expected them to have growth hormone deficiency or an endocrine deficiency, but actually the symptoms they give in terms of describing their fatigue or something actually fits very much into that. And then we will link them back in with our endocrine colleagues. So I think that the sort of almost taking all the doctors out of the clinic makes it more efficient for families, because the families don't perceive that they're there to talk about one thing. They're there to talk about anything and everything about their child's life, where if they see the endocrinologist, they think they're there to talk about their hormones. If they're seeing the neurologist, it's about, you know. So I think in some ways having an allied health professional clinic is a very good model. I would say that because I set ours up, but, you know.
Thank you, Shona, and thank you for bringing that together, because I think what's come across from this session is the passion that individually you have and collectively we share. And the Tash Cornwall describing the Tessa Jowell mission of this Centre of Excellence and looking for badges of excellence, including children and including the rehabilitation pathways, can only possibly reinforce. It could be a tool to help us reinforce what we are saying should be the expectation for all children and families who find themselves in the brain tumour group. We've got many, I'm sure many of us could speak about this subject for much longer, but I think it's only fair in ourselves and our bladders that we do stick to our comfort break. People, please come back at 12:30 because we will talk about data collection. And in order really for us to describe the numbers of people falling into this group, we've talked about this in the past, but we really need to put it into action of a multi-centre database, much like you do for muscular dystrophies, etc., in the country. And so that will be able to describe better the numbers of people falling into this category, their outcomes, and the inequity between regions. So please come back. And then also Anthony Predo is here, coming, who is our NHS manager. He assures me he is going to attend. And I know many of us want to ensure we lobby NHS England to not neglect this group of children and help us ensure that the service specifications and commissioning for all ages, including children, in a rehab pathway for the length of their journeys, which isn't just around their acute care. So come back, but let me now thank the three speakers. We really enjoyed your talks, and we will think about what you've said and work together to support you putting things into action. So we'll pause there. They are recorded, those talks. Thank you all for allowing us to do that. I'll pause the recording and put it back on after the comfort break. Can we get back together at 12:30, please?
Some of you will have heard some of the early slides before, but I'll whiz through those. But it's just to contextualize this present proposal a little bit. So we all know that NHS England wants us to collect outcomes, and rightly so that they can see the efficacy of our service and the cost efficacy. And NHS England did this exercise back in, I think it was 2012, of organising outcomes into these 5 domains that are aimed to cover all the treatment activity the NHS is responsible for. And the idea is that networks such as ours will help support local clinicians delivering this framework in their local systems. So we've got measures of efficacy. We've got domain 1, preventing people dying prematurely; domain 2, enhancing quality of life patients with long-term conditions; domain 3, helping people to recover from episodes of ill health or following injury. So all things that we spend our working lives trying to do. And then domain 4 is about patient experience, trying to make sure that that's a positive one for the patients and families. And domain 5 is about protecting patients from avoidable harm, so a safety aspect. Now, I said we've been discussing this for a long time. We have. We had one of these meetings back in 2015 when we did the exercise of mapping neurorehabilitation outcomes onto these NHS domains with, I think, a considerable amount of success. I won't go through this slide, but out of this came a sense that yes, we could do this exercise, and we need to start thinking about what, if we are going to set up a national database, what would be mandatory key performance indices initially, and what other outcome measures should we be collecting, and something that the database could expand to collect in the future. So we haven't done this from a standing start. There is already national data collection in adult neurorehabilitation. Some centres, as Shona mentioned, Southampton being one, do contribute to UK ROC, which is the UK Rehabilitation Outcomes Collaboration, but that is mainly an adult database, and that it was set up as such. And although it aims to be a generic rehabilitation data set. Certainly in the early years after the setup, it was focused on neurorehabilitation, and it now includes data from all specialist adult level 1 and level 2 neurorehabilitation services across the UK. Now, UK ROC was funded by NIHR, and it was funded on the basis that the work, it was going to do in terms of what outcome measures to collect, and then the feasibility of collecting them, would help to open what Lynn Turner Stokes refers to as open the black box of rehabilitation, because it would relate the rehabilitation requirements and inputs provided to meet them to the outcome and cost benefits of rehabilitation. And Lynn Turner Stokes and her team authored a paper some years ago, which was about acquired brain injury, which showed that rehabilitation is highly cost effective and effectively paying for itself within 18 or 19 months of discharge. And the other thing the UK ROC team did was they established a system for accurately identifying the cost of rehabilitation in adult patients that takes into account the higher costs of managing complex patients. And that's used by NHS England now in adults to pay for specialist inpatient rehabilitation. So this is the summary of the UK ROC data set. So it collects data on demographics, on process issues around patient care episodes. It has the patient characterization tool, which is a summary of the patient's needs as they come to neurorehabilitation. Other measures of complexity of both the patient and their rehabilitation needs, so the neurological impairment scale, the neurorehabilitation complexity scale in the extended form, and the Northwick Park dependency scales, both nursing and therapy. And then their outcome measures are the UK FIM and FAM, so measures of functional status and the Bartel index, and goal attainment scaling, or GAS, is also collected. So when we had the meeting in 2015 and subsequently another one a few years later, we all agreed we would like to have a specifically pediatric neurorehabilitation database. And at the time, we thought things that we wanted to use that database to inform were information about how many patients are receiving neurorehabilitation following acquired brain injury in the UK and where they're being treated, what the patient dependency levels are. Do they differ between different neurosciences centres, or is there a certain amount of homogeneity? What are the short-term and medium-term outcomes after severe ABI in the UK? And how do those outcomes relate to demographic and etiological factors, but also treatment factors, including neurorehabilitation? Can we identify ultimate outcome at an early stage? Is there evidence of relationships between dependency outcomes and the rehabilitation services being provided? Is there any evidence of changes in outcomes with changes in neurorehabilitation provision over time? And coming on to trying to see whether we could do a similar exercise to Lynn Turner Stokes, could we demonstrate that neurorehabilitation is effective and or cost effective in paediatric acquired brain injury? I'm emphasizing acquired brain injury because that's the commonest thing we all deal with. I think the numbers of patients with spinal injury are smaller, and we ought to do this exercise in acquired brain injury first. So we had a subsequent network meeting in September of 2018 in London, which was attended by professionals from a range of disciplines working in paediatric neurorehabilitation in England across a number of centres. And we shared information on current data collections. I remember this is a few years ago now, and there's a list there of the contributing centres, and Liverpool on that occasion were unable to attend, but did share information on what data they collected by email. So actually, it was quite an encouraging exercise, because we found that lots of people were collecting quite a lot of not dissimilar things. So as far as collecting data on process, most centres were collecting similar data on process. In terms of collecting data on patient rehabilitation complexity, all centres were in fact collecting the rehabilitation complexity scale. Some were also collecting the Northwick Park nursing or therapy scales, but that was much less uniform. And when it came to generic measures of outcome, most centres were collecting the King's Outcome Scale for Childhood Head Injury, the Cottage score, and a lot of centres were collecting either the FIM-FAM or the WE-FIM, and some were collecting the PEDI or the PEDICAT. Things like goal attainment, scaling, and quality of life, social and participation at the time were less commonly collected. And bear in mind, of course, that these services are particularly at the moment delivering inpatient rehabilitation, and these are now getting not goal attainment but quality of life and participation, and moving more towards the outpatient scores. And a number of centres were collecting some sort of measure of patient experience. So we agreed at that meeting what we thought an national database should initially collect: demographic data, which, unlike the UK ROC, I don't know that it's changed since, but at the time UK ROC didn't include ethnicity, and we thought ethnicity was probably quite important. Data about the episodes, data about patient dependency. We thought we should probably all start using the patient categorization tool, because it's understood by commissioners. Outcome for the Cauchy score for acquired brain injury seemed already being collected, similarly with the FIM-FAM, although some units were arguing for the PEDI score, and we should do something about goal attainment, and we should be collecting patient and parent experience. We recognise there was some work to do about defining the start of rehabilitation to ensure common systems of data collection, because I know that in Bristol, for instance, we start our data collection when the patient is transferred from acute neurology or neurosurgery to the neurorehabilitation inpatient bed day tariff, whereas somewhere like Southampton have a rehabilitation team who'll start working with the patient on intensive care, and they'll start data collection at that point. So we just needed to tidy some of that up. And we also needed to decide how often functional outcome measures were going to be collected. I mean, obviously the minimum is on admission to rehabilitation and discharge, but we'd hope to collect them more often than that. And we recognise the need to differentiate between discharge from hospital and discharge from a specialist outpatient neurorehabilitation therapy program, if the centre offered that, which again we've heard from Shona, Southampton, for example, does, and so do Nottingham and now Bristol. So we then started trying to take this forward, and we ran into two problems. One was legal and the other financial. So the legal aspects of patient data collection, if you're going to do it on a multi-centre basis, are sort of due to data protection legislation. So you can go down, as we heard at various subsequent meetings, you can go down potentially two routes with this. If you're talking about data collection for a research project, you need to get ethical approval. Ethical approval normally requires consent from parents. Consent isn't required if you're going to use the data for service monitoring, in which case you don't need to go for ethical approval. But we were advised that if we went down the service monitoring route, there may be subsequent difficulties if we wanted to publish any outcome data. We asked around us about, at other sort of networks to find out, whether they got consent for their databases. So UK ROC doesn't require consent, but of course it's different because it involves incapacitated adults who aren't able to give consent, and there aren't parental figures to give consent on the patient's behalf. North Star Neuromuscular Duchenne database, apparently consent is obtained from parents, and similarly from the Children's Epilepsy Surgery Service. But the feeling was that the level of emotion around the getting of consent, the timing of when you approach families is going to be somewhat less in these two groups of conditions than pretty well straight after an acquired brain injury, which has been life altering. So there was a lot of discussion about the consent issue and quite a bit of unhappiness with it. The other issue that we ran into, of course, was how are we going to get this funded? This is not a totally simple thing to set up and run. So we asked NHS England, and the general feeling was that the NHS England totally recognised the national data collection and the dashboard essentially for quality assurance, and they were willing to consider the possibility that resources to allow trust to contribute to the national database could be built into a bed day tariff, if a bed day tariff was how the services were going to be funded going forward. But we were advised that a national database itself, the running of that database, would not normally be supported. So we then thought about research options. UK ROC was originally funded by NIHR. I had a discussion with NIHR, and the feedback was that a database alone, just saying we want to set up a database, wouldn't be funded. But if there were clear research questions, they might be interested. And there's an NIHR programme feasibility grant, so that's a variant of research for patient benefit, would provide the opportunity to demonstrate the feasibility of a national data collection. And then we asked various charities and asked the BPNA, and we didn't get anywhere with that particularly. So what's happened since then, and we've discussed this topic on a number of occasions at these meetings, is that prolonged disorders of consciousness have sort of risen up, I think, the sort of interest of researchers. So we all know that severe disorders of consciousness, including vegetative and minimally conscious states, represent successive stages in the emergence of patients' coma, and that patients with coma may evolve to vegetative state and then minimally conscious state, or of course they may, so a small number may remain in those states with a prolonged disorder of consciousness, which is defined if you've been in that state 4 weeks or longer. Now, excitingly, various pharmacological and surgical treatments have been recently proposed for patients with PDOC, as we've discussed at this meeting before, and they're aimed at improving functional connectivity and increasing the rate and extent of recovery. Very few clinical trials of these treatments have been conducted, and that's particularly the case in children. Why is that? Well, barriers to designing research trials include our current limited ability to select which patients are most at risk of failing to emerge from PDOC and which, will emerge anyway. All novel treatments suggested may have side effects, and treatments such as deep brain stimulation and vagal nerve stimulation are surgically invasive. So clinicians are only going to want to use these sort of treatments if there are clear indications. So if we're going to select patients for inclusion in clinical trials of new treatments, we need simple, widely accepted outcome descriptors and an early understanding of the likely final outcome in a given patient. Because I think the feeling in the literature, and I think we would all agree with this, is because of neuronal plasticity, you're more likely to get a better outcome if whatever your intervention is applied early, than if you wait for months and months and months until it's obvious the patient's not emerging from a minimally conscious state and then go for the outcome. So in terms of thinking about types of data collection in this sort of context, obviously there are sort of two ways of looking at it. You've got a limited number of single points, for example, after medical stabilisation, on admission to neurorehabilitation, at hospital discharge, or various set time points after the original injury. Or you can have data as well at multiple points, perhaps generated at the weekly or fortnightly multidisciplinary meetings, or collected weekly as part of a research project. And of course our therapy colleagues collect serial data as part of their routine assessments. So the possible benefits of multiple data capture is that it permits you to construct recovery trajectories. And recovery trajectories that people have been talking for some years about that might actually permit greater understanding of a patient's likely outcome at an earlier stage, facilitating decisions about care. And it may also be that recovery trajectories may help us unpick the different factors that are going to influence final outcome. So none of this is ultra new. Back in 2008, Rob Forsyth published a paper in Archives of Disease in Childhood, where he'd used data on just over 100 patients from an American pediatric neurorehabilitation facility to model the expected recovery in children who'd suffered severe traumatic brain injury. And that data was repeated WE-FIM scores. And they analysed the data using a statistical technique called mixed effects modelling, and they found that the curves of recovery showed a characteristic sigmoid form with an initial slow phase, a faster improvement at mid phase, and a late plateau. And from their findings, they concluded that simple models can be built to predict outcome trajectory, and that this may help advise parents. They weren't thinking so much of clinical trials at that stage. There have been some other modelling studies since then in paediatric acquired brain injury. So Kelly in 2015 published a paper examining the impact of gross motor function measure in characterising trajectories of recovery. And they reported a strong relationship between type of ABI and the nature of the recovery curve, with hypoxic injuries showing poor and slower recoveries, and also slower recoveries in younger children. And then Molteni analysed patients with WE-FIM scores again, and again, like Rob Forsyth, concluded that the type of recovery trajectory of the patient could be predicted based on their initial functional condition. So we had an MS student, Edlison, Aruda and I, in last year, that we asked to do a piece of work for his MSc project to assess the feasibility of modelling predictive factors and recovery trajectories using our weekly Cauchy scores, which are generated at our weekly MDT meetings as the outcome measure. And we were able to give weekly scores for patients over a 18-month period. So I think that was 70 patients. And the project suggested that this sort of approach was feasible with Cauchy scores, as it had been with WE-FIM and the gross motor function score. So subsequently, Edlison and I have received Pump Prime funding. It's £25,000. It's small, but it's been awarded by the Knowledge Exchange Programme of the International Centre for Mathematical Sciences to develop the methodology further and explore the possibility of undertaking a national study, because the Knowledge Exchange Programme is about bringing mathematicians together with other people, including potentially clinicians, to try and share expertise and design research studies. So I'm going to hand over to Edlison now, who's going to tell us more about the methodology and what we're proposing. And then I'll wrap up after his presentation. Edlison, shall I stop sharing?
Yes,
Sorry.
yes.
Yeah.
Thank you.
I'm trying to get back so I can stop. How do I stop sharing?
I think I can share mine now. So are you seeing that? The chat? Okay. So the overall idea here, when Peter sponsored a study for, we have an MSc program here in which we solve problems from partners, and Peter was one of our sponsors. And this is a very interesting project that I fell into my lap, fortunately. And when I got this study and we talked to Jonathan about it, it reminded me of an earlier study that I had done before on pathway modeling for lung cancer patients in Wales, but it was diagnostic pathways. But the idea being that we can perhaps think of a personalized modeling of patient pathways, which is something that the NHS is now wanting, or there is some guidelines on the NHS that they want personalized healthcare. So can we predict, or can we help understand what the personalized needs of a patient will be based on their characteristics? So that is the overall idea. And when I started the other study that I'm mentioning, I'm not sure whether the controls are, you can see the controls or not. Let me just take them out. So you can look at pathways as random demands that happen over time. You arrive, it's like going to a supermarket, you don't know what you're going to buy. The patient arrives at a pathway, you don't know what they will need. And in this case, which was a lung cancer diagnosis, the needs might be CT tests, PET scans, biopsies, and so on. And you can have very different types of clients arriving at the supermarket, and of course, very different types of patients arriving in any pathway. For example, there is this patient here, and 4 successive CTs, and they found out that no treatment was needed. It took around 2.5 months for that. The other one, same pathway, 100 days. And then there is this person here that had 9 tests until they found out that they had cancer and need radiotherapy. It took 54 days, which is longer than the guidelines. So one of the issues is that, yeah, you want to enforce the guidelines, but you need to ensure that you have resources. So the modeling here was more focused on finding how many CTs would you need, how many PET scans, considering that you have all these pathways coming together and they probably use the same resources. So the modeling is the idea that as the patient traverses the pathway, you have more information. In diagnosis, for example, if you have a CT scan, then this is some information you have, and based on this information, you might choose to do a PET scan later on to refine your knowledge of the patient condition until you decide whether they don't need treatment or whether they should be treated. And you can start with another test, but here the idea is that if you have a sequence of tests so far, that's sort of a proxy for the information you have on a patient. So you can think of this as a Markov chains or transitions and probabilities. For example, here you have patients that have CT, 20% of them roughly have a PET scan later on, and so on. The idea here was not to have a look at personalized pathways per se, but it was just to find out how many resources we would need, considering that many patients can come in a given day for many different diagnostics pathways. But even in that, you can have an idea of what's going on based on this Markov model, which is very powerful. You can sort of project into the future the pathway and have a look at what typically happens. For example, here, if a patient has an initial CT, then this is what typically happens. Most of them will have no treatment, some of them will have surgery and so on. But then if you go to a PET scan, then this indicates that the probability of surgery is going to increase, and the probability that you do not have cancer is going to decrease. So this might help you manage patients in an individual way by looking at what they have done so far and the probable outcomes, and therefore the resources you might need later on. And also the personalized care that these patients might need, rehabilitations and so on. Other things you might want, and they were keen on that in NHS Wales at the time. This was at the University of Cardiff. It was looking at these pathways. Are these similar? Can we find groups of pathways in the standardized care? Which is something you can do with the Markov chains as well. But the Bristol data set, it gave us like more things that could be done, and more information, and a little more freedom perhaps to have a look at longer pathways. So in Peter's data set, we had demographic info, we had date of admission, length of rehabilitation, which is not essential in here unless you're just doing a regression looking at initial and final points, but I'm about to tell you that it's mostly important to have a look at what happens in the middle. And then we had weekly COSH scores during rehabilitation, which are just gives us an idea of patient, how they are faring in their recovery, what the level of independence is, type of injury, and RCS scores, other scores as well we did have. So the overall idea of the project that we submitted was to have a look at these pathways. So looking at realized pathways. So what happened to each patient? What happened depends, of course, on the social demographic information, but also depends on what was done during the rehabilitation pathways and how they progressed along the pathways. And then the idea being that we can use regression, not just to find a static measure of trajectory, of expected trajectory, but to try and create a personalized model, considering that each patient is different and that patients do have different outcomes, even if you do the same thing to them in the same situation. So there is an uncertainty that the trajectory, we will looking at the trajectory, you have more information on that, and it will avoid you just looking at a static point and trying to project the whole future, which is quite complicated. And then you can create a sort of personalized model. So this is not a trajectory, but a stochastic model that determines possible trajectories for each patient. Again, considering that patients are individuals and they have random outcomes if you do something to them. And then you have a tool for personalized pathway prediction. And of course, we need to validate it with people who know about the problem, such as Peter and yourselves, and then redesign if needed. We did one iteration of that in the MSc project, but it's a 3-month project, so there's much more to do. So what's the difference here is that pathways, they include demographic information, and we are not modeling trajectories, we are trying to model the whole pathways, considering that patients are different. So the existing approach, such as the ones Peter mentioned before, they are either trying to predict only the outcome, and then you are sort of ignoring that there is a trajectory between arriving and coming out, and that it's probably the things that happen in between that determine the outcome, and that these trajectories have different lengths, and therefore they're not readily comparable, probably. Or you can model via survival analysis, but the problem with that is that you are assuming similar patients will have always the same curves, which is not true. As I said, even the same patient, if you do the same thing to them, they may have different outcomes. So analyzing the uncertainty in the pathways is very important. That's the point of the project as well. So, and how can you do that? So you can do that by looking at data sets in, like, if you have a sequence of states, a sequence of outcomes. In Peter's data set, we did have the weekly COSH score. So we can have, looking at the current COSH score and all the relevant information I can have on the patients, such as what happened to them at arrival, their conditions, how it progressed so far, and also the demographic factors. I can try and predict what happens next week. What's the score next week? And then I can build across those predictions to try and find out possible trajectories with all this likelihood and for the likelihoods of different possible trajectories. And then having these likelihoods that you're better informed to take a decision on treatment, as opposed to a single curve that may not be actually the curve of that particular patient. So the idea is to allow for future prediction, considering the underlying uncertainty, and we can rebuild pathways along with their probabilities. So how would that work? So this is an example of a model, a personalized model. So this is not a model for the cohort. This is a model for a given patient. And then we have, like, if this patient is with Cauchy score 3A, then next week they will be 5% probability that they will be 3A again. 53, they'll progress to 3B, and so on. And then you can see that if they progress to 4A, then their trajectory will be different than if they go to 3B. So actually, there will be multiple things that may happen, and the idea here is find out what those trajectories are and what the likelihoods of those are. So this is just for one specific patient of interest that had anoxia and apoxia. So it's sort of a proxy patient for us to have an idea and validate the tool. So to look at pathways, as I told you, you can have a look at how they enter and how they go away. And one first thing you can do is have a look at it. So this is the Cauchy score at admittance, and these are the Cauchy score at discharge. And you can see that the higher the score, the better the patient is. And you can see that the center is doing its job. Most patients start at lower scores and most patients finish at higher scores. But if I want to analyze individual patients, individual conditions, or select patients for further treatments or not, then I need to have to get more personalized information on that. So, and that's where we come back to the framework that we are proposing, in which we look at realized pathways to understand what happens next week, considering everything that has happened so far and the patient demographics. So in here, we just use multinomial regression because our outcomes are Cauchy score 3A, 3B, 4A, 4B, and so on. And then you can have a model telling you if the current score is 3B, what are the important characteristics for that determine the transition next week. And then we can find out here some things: gender, age, and admission, drive time, which is sort of a proxy for where they live, whether they have autoimmune disease, and so on. And of course, those scores will have those things. They won't have the same impact on all patients and on all initial conditions. Like if you have 4A, the gender may be less relevant than it was for 3B, and so on. So we can have that sort of granularity on the initial state and on the patient characteristics, and then this will give me an idea of what happens next week. And then to model what happens next week, with a given patient and all possible initial conditions, we can just use the regressions, and the regressions will generate as a matrix in which we can represent by this graph, which is sort of easier to visualize, that patients are transitioning between states. And then, so the machine learning part will be the regression, this part here. And then there is the stochastic modeling, which is applying that to an individual patient. And then you can build the personalized model. So this is the same personalized model. And then with this personalized model, I can have an idea of what happens for patients depending on how they arrive. So, for example, here we have a patient arriving at Cauchy score 2A, or 3A, sorry. And then what's going to happen likely next week, 2 weeks from now, and so on. Then you can see that as expected, the red is going downwards, and then you are becoming more green, or which means that there is an increasing likelihood over the weeks that the patients will get better. And it's very unlikely that they retain the state that they were initially in. This is for a given patient, a given condition. But then for other conditions, this is another patient, it may be that the recovery is slower. And then we can see that for these patients, it's very unlikely that they will progress very quickly. And then you can see across the weeks, the red is still there after week 20. So this is probably one that will recover very slowly. And we can have some ideas of what to do about that in a clinical perspective. So to wrap up and not take too much time, the idea is that we can, with the right data set, build personalized pathway modeling for customized or personalized recovery trajectories for patients. So each patient will have their own rehabilitation trajectory, and we can infer what's probably going to happen with certain levels of probabilities for the next weeks. There are some approaches that try to do that. They are sort of reinforcement learning approach, but typically they are very limited and they have mixed results, and they typically look at, they are focused on the model. So they look at very poor data sets with outcomes in 1 week or so, loads of patients, but then you don't observe them enough to be able to infer a pathway. The proper choice of the state is crucial, right? So how we characterize how a health state of a patient is. And for us modelers, it's sort of immaterial, but it depending on the state, on the problem that you're looking at, you have different measures. And fortunately for this problem, we have the Cauchy score, which gives us an idea of how the patient is going across the weeks. And then one of the ideas of this project is try to validate this further, have more looked on the data set and talk to you guys to see whether it's performing well, whether these trajectories are trajectories that you would expect from given patients. But here there are also things that you might want to consider. For example, if you think of rare conditions, you need a larger data set so that you can observe rare conditions, right? So a national study will help with that. For rarer conditions, for example, in Peter's data set, I think there is one condition of interest. We have a single patient, and we cannot infer much from just one patient. And then validation, and the idea being that we are looking at possible trajectories and probabilities, not just a single outcome, which probably may be unlikely for many patients. So a personalized model will help us actually try and give personalized interventions as opposed to those cohort models or just protocol studies. And I think I can stop now, and then I can come back and answer any questions you might have.
So thanks very much indeed, Edison. I'm just going to show my 3 slides really, really quickly, because I'm conscious that Anthony Prudo's and we want to speak to, because he's from NHS England, needs to leave at 1:30. So I'll just see if I can share my screen. If I can't, we'll delay. Are you doing this for a minute? Let's come back. So basically, I think that what Edlison's been speaking to is a really potentially powerful tool that we could use to ask the question: can we identify patients who are going to have a poor outcome, who might be suitable for some of these novel interventions, patients who are effectively in PDOC, which they will be if they've got acquired brain injury and they've currently got a poor outcome. So I think the primary aim, if we're going to make an application to NIHR to the research for patient benefit sort of feasibility arm, which would go up to a maximum of 250,000, would be: can we take retrospective data from the various centres in the way that Edlison's taken our retrospective data to start addressing whether early outcome data plus demographic injury specific data and possibly some management data, can we predict later outcomes using that data in the same ways as we've done with a much smaller data set, and therefore have a much more robust ability to predict? Are the early recovery trajectories more powerful than early single data points predicting later outcome? And then the other part of the project could be: can we demonstrate that it's feasible to collect neurorehabilitation data prospectively on a collaborative basis? And and that would then potentially give us the framework to identify patients who might be at risk of poor late outcomes and perhaps should have other treatments. Obviously, if we are prospectively collecting a national database, we'll be able to answer the various other questions that we want answered, like how many patients are receiving neurorehabilitation, what are their dependency level, and what are short and medium term outcomes. And we could potentially explore, but this will be more difficult, whether the relationships between dependency outcomes and the currently provided neurorehabilitation services in the various centres, and whether or not we could use this data set to prove that neurorehabilitation is effective. I don't know, but it certainly would give us the opportunity to have a shot at that. So we've got ethical application that's going to be considered on Monday for Edlison to do some more work on the data set that Jonathan was working on. Jonathan had previously had ethical approval from the University of Southampton. This has been a massive piece of work putting this in. So I think it's going to form a really useful template if we then want to go for a multi-centre IRIS. We've got some funding for knowledge exchange for a 1 or 2 day workshop, which we'd like to hold in Bristol or Southampton. I think it needs to be face to face and towards the end of October or in early November. And the workshop be open to representatives from any interested centres. It doesn't matter whether you've got commissioning funding for neuro rehab. Attendance at the workshop doesn't imply that you're committed to join the study. It's just the opportunity to find out more. And I think we need to use the first bit of the workshop to get various centres to present what their data they're currently collecting now, because there may have been quite a lot of progress on that since we last did this exercise 5 years ago. And then the second part will be discussing what exactly are the research questions and developing the methodology. I won't take questions now because I'm going to hand over to Anthony, who's going to give us an update from NHS England. How do I stop sharing?
Yeah, that's fine, Petter. Thank you. Well, and yes, well, thank you, Edison and Petter. And we all perhaps have many questions to ask you about that and the prospect of a workshop to move that database on. But we can now welcome Anthony Predo, Senior Manager for NHS England Women and Children's Programmes, who has been a great ally of ours and worked with the Neurosciences Clinical Reference Group. Anthony, we've had a great morning talking about the problems that children and young people with acquired brain injury from tumours face in terms of their lifelong journey and the access to rehabilitation. And the launching of Success Charity in relation to that. And we've referred to nice guidelines that exist, but we want to hear from you now, because you've come to us before many times, the last meeting with Sally and Charlie, talking about visiting centres up and down the country and the service specification. So thank you so much for giving us your time. I'm so sorry I have barraged you with emails, and thanks for managing to get here.
No, Jane, to be honest, if I hadn't known a good few months ago this was coming through, I would have tried to carve out the time, because it sounds really, really interesting, all of this. But let me just give you a quick update in terms of where I'm at. So I just wanted to say, first of all, that NHS England is still committed to publishing a revised service specification for paediatric neurorehab. And the reason why I wanted to say that is because this piece of work has taken ages, but all pieces of work are taking ages in NHS England, unfortunately. But we are still committed to doing it. And in fact, yesterday I had a meeting on this internally with finance colleagues, warming them up to the fact that we are likely to need additional resources to support this service specification. So that side of things is also being considered as part of the process. Jane, the work that I did start with your team actually slipped again, and slipped quite badly again because of all sorts of different reasons. And the additional resource and help that I had through Sally stopped. So we've been struggling to kind of get this back on track, but we do have the revised service specifications scheduled into the Clinical Priorities Advisory Group meeting in February 2024. Now, I know that seems ages away, but it actually isn't in planning terms. So it's scheduled to go into that meeting for consideration and discussion. I'm still working with the units across England to test out with them whether or not this service specification, i.e. the revised service specification, is deliverable. And the overwhelming feedback that I'm getting at the moment is, well, it's not, because of the additional resources that people would require. But I'm also receiving feedback, Jane, that, well, can we have a flexible approach to this? And could we have a hybrid type service specification model for those units that would really struggle to actually kind of develop inpatient rehab beds, for example, and parental accommodation that would need to go alongside all of that, and, you know, the things that we know about. So I still have to pull in information from all of the units, because I haven't spoken to all of the units just yet. And we are wanting to spend time not just asking them to provide us with information, but we're actually wanting to talk to them. And indeed, Jane, I've actually made arrangements to come back and speak to some of your team again, just to test out the Nottingham model, and whether or not, as part of that hybrid, we could weave some of those features really into that. I've asked to speak to Petter and the team in Bristol, again, to just understand the detail of their model. And I've also had time with Shona at Southampton, and I think Shona's in on this call. Mm-hmm. And we had a really interesting session with Southampton, and we want to go back to them and revisit some of the themes that they actually kind of took us through. So I think that's a long-winded way of me saying to colleagues that we're still on the case, unfortunately. We still haven't finished the work that we've set out to do, but we do have a deadline date that we've been asked to talk to CPAG about, which is good. So I am working to a February date. Petra, I will come back to you about the Bristol visit, if that's all right, because we would love to come down and see how all of that works. And we had quite a long and lengthy meeting with Newcastle colleagues. And again, I'm trying to get back into another meeting with them, Newcastle colleagues were taking some business cases into their trust management team process. A lot of it linked to the requirements of the service specification. But I need to find out where they'd got to as well. But again, we were getting some clear messages back from Newcastle that the service specification as written would be challenging. So there's still a lot of work to do on this, Petter. And I also think the service specification at the moment is still quite weak on outcomes, and we probably do need to do a bit more work on that. And the final thing I just wanted to share with you was that I just wondered whether the service specification could also be a little bit more explicit. This has come back from the feedback that I've had from colleagues up and down the country. Could be a little bit more explicit about the neuro rehab prescription, and almost set a set of national standards around what that prescription should look like, and the interface therefore with integrated care systems and their services. So I think the service specification outline as is, no one's disagreeing with it. No one. Everyone's struggling with it in terms of resourcing it and a readjustment for their services to meet it. For some of them would be quite challenging. Therefore, the need to think a bit more flexibly about a hybrid model. And as I said, probably a bit more work needing to be done on outcomes and prescriptions. So there's some practical things that I still need to do in advance of that February deadline date. And basically, I'm just using all of the people that I'm now meeting up with to actually take that advice from, which is why I wanted to come and see your service, Petter, and because I just need to compare that with others and how it works. So that's what we're working to, Petter and Jane, that February deadline.
Okay, that's brilliant, Anthony. Thank you for continuing to drive it forward. Would it help you if if members of this network were to get together and perhaps we're going to get together in October or early November to discuss the whole issue of outcome data collection. So we're going to have up-to-date views on that, not something that goes back to 2018. Would it also help you if we had a separate meeting to think about the neurorehabilitation prescription? Is that sort of coming from the major trauma world, that suggestion?
It is, Petter. It is coming from the major trauma world, but it's also coming from colleagues who work within paediatric neuro rehab, and it's primarily linked to the challenges that they actually face when it comes to that interface with community services.
Yeah.
So yeah, it's almost kind of wanting. We probably need to describe parts of the service specification in an integrated service type way.
Yes, yeah. So what we do at our discharge planning meetings for patients who are going to the deep south of our region and therefore are too far away to have, the outpatient physio, OT, speech and language as a step down, which is what we do to Bristol and Somerset and Gloucester patients, is what we actually ask commissioners to provide some additional funding to help with that. So I suppose that discharge planning meeting sorts of writes a rehab prescription, but if we could formalize that process, that would be good.
Anthony, are you happy to have some questions from other delegates on the call?
Of course, Jane, yeah.
I think because the collaboration with other clinical reference groups may be helpful as well. And of course, Helen Spadias is on the call, who has been working with the cancer representatives and cancer reference group in relation to the rehabilitation of children who've had all these extremely expensive and ongoing expensive treatments, but are lacking in the rehab. Helen, do you want to ask any questions to Anthony?
Helen, I think you're on mute.
Yeah.
Sorry. If I may, and I'm coming at this slightly off field, but I'm a general pediatrician who's become an endocrinologist. And I've seen, I'm not as au fait with a lot of the super specialist services that exist, but I have been working for 25 odd years at Great Orme Street, which seems to be a bit of an isolated centre of its own, as I hear.
Yeah.
But my frustration has been that there are lots of different commissioning services, brain tumor, one for brain injury, one for rehabilitation. And then there's another one for rare tumors. But the concentration of all the commissioning has been funded for cure directed at proton radiotherapy, chemotherapy, billions, which haven't actually altered the survival at all, because survival, 80% survive. And and there's increasing evidence now that we need to look at how they survive, at least children. And many of them can do much better than they do. And I feel if we could deflect some of that funding in rehabilitating them, instead of throwing too many drugs at them, and get maybe 60% more into employment, that we don't just look at the hardest hit, but we look at everyone. And I'm trying to work out, where should I concentrate? And, should I try and concentrate on the brain tumor, cancer commissioning? Should I concentrate and try and, sounds like you've got a very big remit, but I can't help thinking that these children and the more rare diseases we treat, rare commissioning group as well, all these congenital children, they all have brain injury, acquired or congenital, and neurodevelopmental hypothalamic pituitary injury. And even the trauma group, they have terrible immediate adrenal and hypothalamic salt wasting crises that are not properly managed because everyone has to call an endocrinologist, and yet endocrinology is not always funded to deliver that. So I caught onto your word integrated care, and I wondered whether part of the prescription is actually identifying which professionals need to be involved and according to the level of the injury. And I've been trying to think that at least where brain tumors are concerned, there's more of a focal brain injury. So I was trying to think that you might need a different prescription, at least to separate those with the midbrain from with the peripheral. And it's not treatment related, it's actually tumor related and lack of rehabilitation. So I think some of it does need to stay within the cancer commissioning, so that we all learn from each other, and it should be actually a mandated part of cure, in my view. Why are we curing them in the first place?
Helen, I agree with all of that. I genuinely do. And I don't know whether Charlie Fairhurst is in the meeting today, Jane, but
no, Charlie isn't able to be here.
That's
but
fine.
I'm obviously feeding back, and obviously he'll be very involved in the moving on the service spec, because he's chairing the CRG, isn't he?
But the reason why I mentioned Charlie's name, Helen, is because Charlie talks about that all the time, and the frustrations that he has with funding generally anyway, because you're absolutely right. We actually do have funding in all these different pots, and they actually don't always contribute to the stuff that we're interested in. So Helen, I actually think you need to come along and talk to my Pediatric Neurosciences CRG, just so we can get joined up on this.
I'd love that.
And yeah, because I actually do think there's something in what you're saying in terms of identifying the different professionals that need to be involved in thinking about that from a prescription point of view. So why don't I get you an invite to the next clinical reference group? And why don't we actually include what you're describing there as a theme that we need to pick up as part of the review of the pediatric neuro rehab service spec?
Thank you.
Good. Well, Helen, I'll get your email address.
I'll give it to you, Anthony.
Brilliant.
It'll be fine.
So
So
I'll be in touch.
Yeah. Right. So the action for us is obviously we're going to talk about database workshop. We can think about helping with the outcomes and
Yes,
this
please.
neuro rehab prescription. We've got a lot of therapists on this meeting today too, who will say to me, well, it's not working in major trauma either, so neuro rehab prescriptions, because there aren't any teams out there to give the rehab. And that's where it comes back to integrated care boards, and the integrated care boards need to be alerted to look at what is in their areas that could be put in place to cover rehab. And my last point is, this extra funding, these children are often in hospital anyway, in an acute neurology bed, and the parents are in the parent accommodation anyway. I mean, we aren't mystifying up a group of children. They're already in our service.
And they probably cost less, as indeed you've shown, Jane, if they could be discharged earlier. Because
if they had the acute rehab. So there is some, it's in different pots, and the fear about the cost may not be as bad as actually it is.
Well, then it might even possibly be cost saving. I mean,
exactly. Anyway, but don't you can see Jane's head, it's sort of one of those emojis when it explodes. Well, I'm doing that.
But I think the rehab prescription is a really good idea, because what we found in the Southwest is doing this, what is effectively a rehab prescription, but isn't called that, has got commissioners so irritated with shelling out pots of money for individual physios or OTs or speech and language therapists, or all three, that they're actually beginning to create posts of therapists with an interest in ABI to pick this work up. So I think it can drive change.
Okay. Right. Jane, I am going to have to go because I've got that perinatal pathology meeting. I feel so rude about this, but I will be back in touch. And I've noticed Jenny Smith's also on the call today, and Jenny and I are planning a meeting shortly. Jenny has recently joined the CRG, so we're catching up as well about some of these areas too. So let's think February. Let's get to a position where we can try and pin down some more explicit outcomes. I'll definitely reach out to Helen and we'll have that conversation inside the CRG. And Petter and Jane, I will be back in touch in relation to both of your respective services, because I actually think that the two different models work. We just need to kind of be a little bit more, I think, confident that you actually can have a mixed economy approach to this. You don't necessarily have to have, a single approach to this, but let's find the time to actually get into those meetings in the detail. But yeah, I do need some help, because if I have to hit that February deadline date, which I've been told I have to, I really do need some support to get this over the line. So I will be back in touch.
Perfect. Thank you so much, Anthony.
And sorry, Petter, for having to leave. Sorry about that.
Yeah, that's all right. Thank you very much for coming.
Cheers.
Bye. Thanks.
Thanks, Jane.
Thank you.
Okay, well that's good news, because Anthony's still trying to take this forward, and what we've got to do is make sure that we provide him with the evidence to get it endorsed by the clinical priorities meeting, isn't it? So lots of work to do there. So Jane, did you want to say, just sort of coming to the end of the meeting, did you want to say anything about the matters arising from the last one? I've got something to say under any other business.
Thank you. Thank you all. Well, the minutes of the last meeting are on the BPNA Special Interest Group page, and the action points really were to hear back from the Anthony and Charlie Ferris regarding the service specification and moving the database on, and so we really have covered that. I think we should now just go back to talking about your workshop to look at the database, because as Shona said in her presentation, the way Shona was able to build up that service that many of us may admire in Southampton was because of data collection.
Yeah, absolutely.
And all of us, if we've had any successes in relation making a case to our specialist commissioners in our regions, it's with data. And so we have heard about that fantastic insight from the MSc of your colleague is Edison told us about this, you know, these economic models being applied to our health economy or health situations. It just seems to make so much sense what he described, and individuals change. We've argued and wondered about, should you start the rehab clock at day 14? Well, does it really matter if we start our clocks where we collect the data from different places? It's the individual child's trajectory and change which can stop us having to worry about that. And if we can feed this data into a collective model to show that trajectory change, and also collaborate because of the rarer conditions, what helps those rare? Is there any model that works better? And from the cancer best practice guidelines, what they did is they looked at children with acute leukemia from many centres, and they looked at what was the best chemotherapy program to give to them. So we have to do this. So Peter, do you want to pick up now? What we need to think about is collaborating with you on that workshop for data collection at the same time as supporting the CRG right to service spec.
So I
think. Can I
think,
just say one thing about data? Sorry to interrupt you, Peter. One of the things that we did in Southampton was not focus on other people's data. And I know we're trying to all be the same and joined up, but actually, in fact, Nottingham did the same, looked at their own data. Where were these patients? How long were they staying? What input were they receiving? Could we change anything? Or actually, what was our own experience? So then each year you're comparing the same data with the same data, because you're collecting data within your own environment.
And I wouldn't in any way want to stop you doing that, show.
No, but what I'm thinking is that in itself is quite powerful for local commissioners.
Yeah, absolutely. No, I totally agree.
They can see that actually these patients are there. And so whereas if we try to get too kind of broad across the UK, you sort of lose sight of what's happening where. And I think we need to do the kind of joined up thing, but we also all need to have our own data.
Absolutely.
For, you know, every year we have 10 patients with this, their length of stay is this, they're receiving this amount of input. And how would that look different if we either had more money or different facilities, or the patients went elsewhere? But those patients are already here. They aren't sitting somewhere outside all our hospitals. And I think we really need to focus on collecting our own in-house data.
I totally agree with you, Shona, and I'm not in any way suggesting that you shouldn't be doing that. What I'm just wanting to explore is whether we have enough communality of data to actually get some funding to look at that using the sort of methodology Edlison's talked about, because that might actually be really quite powerful because it would be a big database in terms of identifying the patients who are not going to do well, who either, you know, perhaps if they've got a prolonged disorder of consciousness, should be having a whizzy novel treatment, or maybe they should just be, if they're in a centre that doesn't have much in the way of rehab, being rapidly transferred to somewhere that can do their rehab. You know, that's the Edlison's concept of the personalised pathways. I think, Edlison, you'd wanted to say something, hadn't you?
Yes, so I completely agree with you. And as an engineer, I typically start with a small problem that I can handle, and then we can we can go bigger. But the problem with with looking at your own data is that it has its limitation. For example, if you are trying to build a new pathway for anything, and then but you only had one pathway in the past, So you always use CT, never use X-ray. How you never know whether X-ray is better, but you perhaps looking at another center that uses X-ray, you can compare. So that's the overall idea. The data can complement itself, right? And we can treat other situations which you don't have in your center, or see more patients of those rare events that you seldom see in your center in a larger data set. But I please do keep collecting your personal data sets.
So can I ask people whether if we said that the meeting, the two things we need to do, and I think what we should probably do is send a survey monkey around after this meeting, because we also need to capture people who haven't been able to be here this morning. But would people prefer a one-day workshop where we spend the morning thinking about what data people are currently collecting, then the afternoon thinking about what a research study might look like? Or do people think that that would be too crammed, and also it probably means staying overnight the night before if you're traveling any distance? And would people prefer to have a 2-day workshop and perhaps start in lunchtime and then have a second workshop the following morning? Is there a sort of an immediate reaction that anyone's got? We were thinking about the 31st of October and the 1st of November. I don't know whether people feel that's too soon, but it sounds if with Anthony and his deadlines, that might be quite good timing. Does anyone want to shout out?
I know it's half term up here, but I don't.
Is it half term? Or we don't want to have it at half term? It's the week after half term where I am, but if it's a half term week, we'll have to have it the week after. Yeah,
I'm having an operation that day. I'm having an operation that day. I'm having my shoulder fixed.
What, on the 30th of October? Well, what about the week after that, the second week in November? Will you be sufficiently recovered?
I'm on holiday in October, but
first week. Can you do first week of November, Shona?
Yes.
Yeah.
You find a day, perhaps with Survey Monkey or something. You put some dates.
I'll do a Survey Monkey with some dates.
Right.
I think I was just going to say, following on from Shona's point, I think absolutely I agree. Like with the whole data, doing both lots of data. I think what we need to do is just be really mindful that we're not getting teams to duplicate.
No, absolutely not.
And make sure that we're not having to input into too many different systems.
Well, I think one of the things that I've got a meeting with one of our R&D team to explore is whether or not if we did put in an application for NIHR funding, whether we'd be able to get these, I still call them MCRN nurses, but they call someone else now, aren't they? But those research nurses to actually take your database and then input the data into the national data set. Because I totally agree that you guys shouldn't be doing that. And if we were asking you to do it, I think we'd have to put time for a therapist to do it into the grant.
Can I ask, and forgive my ignorance, but as I understood it, the data sets are very much around the patients you already treat with the more severe global types, not looking for new outcomes for the milder focal types that we're talking about? Or will that be a separate thought, or is that, you've obviously got a major work program in place, just to know whether and if I should be.
So that's a really good question, Helen. The focus of this is driven a bit by what I think NIHR will be interested in funding, which I think is a feasibility study that would potentially lead on to randomized trials of novel treatments in patients with very severe acquired brain injury. But we all recognize the need to expand our outpatient provision, and that's what's different about this new service spec that Anthony was talking about compared with the old one, where we were explicitly told we couldn't put anything about outpatient services in it because they didn't exist at the moment, and you weren't allowed to describe something that wasn't already funded. So we have got it in, the idea of ongoing follow-up, being able to see a patient again that we saw years ago, all that sort of stuff. but at the moment, I don't think the database is going to cover them. But in the fullness of time, obviously, we would like to collect data on them. Does that answer your question?
Yes, yes, very much. Thank you.
Okay, anyone else got any questions? So just to cover, so do I take it that there are enough people who'd be interested in coming to a workshop on the database? And do people think, I think it would be easier to do it if we do it face to face. If there's a very strong body of opinion, and I'll put this on the Survey Monkey, that actually realistically it would be better to do it as a 1 day or 2 day online meeting, then please say, and we'll rethink that. But we have got some funding for travel expenses and things if we wanted to do it as a face to face thing. The other quick update on under any other businesses, I think we've talked before about having a spinal cord injury database. I think given that, you know, looking at deadlines for research for patient benefit NIHR applications, the next round, although they haven't publicised on the website at the moment, is likely to be an outline application going in March of next year. So I think we need to focus on acquired brain injury. But obviously, if we start really getting on with acquired brain injury, then we can have a separate think about acquired spinal cord injury. We'll have a group of people who are interested, and we can pull in some people from the spinal cord injury world, as we've discussed before. In terms of the closer links we've talked about between neurology, neurodisability and neurorehab in terms of designing the medical curricula for consultants who end up working in neurorehabilitation. That got a bit stalled when I was off sick, but I've emailed Catherine Martin and we're going to start that up again. And then we need to have a transition meeting, I think, at some point. I feel a bit stuck in that I know that transition's done absolutely appallingly in Bristol. I think Shona is point, you know, what you were saying, Shona, I think it's done better in Southampton. But if anyone knows of any sort of models of excellence in terms of transition that they could let Jane and I know about, then that would start informing us in terms of speakers for that. The next meetings, there is going to be a SIG meeting, a special interest group meeting at the BPNA, which is the 24th and 26th of January next year. It's only going to be 45 minutes, and I think we'll just do what we've done in the past and just have a brief business meeting, but at least it keeps telling the BPNA that we exist and we're doing stuff. But the next main meeting is in Southampton, and Shona's going to run that, aren't you, Shona? And you're thinking of themes as we speak.
Yes, unless anyone's got a very pressing theme. We were thinking, actually, along with what Helen was just saying, thinking about some of the more milder impairments that actually are still quite significant. So the group that we usually refer to as the walking wounded group, so physically look quite good, but actually have got significant other difficulties, cognitive, behavioural, that sort of thing. Thinking about that as being our topic, unless anyone's got something else that they feel is more pressing.
I think that would be great. Terrific.
Anyone's got any good speakers that they think might like to come and talk, please let me know, and we will get them in. We will be touting amongst our psychology and psychiatric colleagues to see if we can find somebody to come talk. I might actually ring Jenny Limond, because I think she might be quite a good speaker to get.
Yeah. Somebody's just asked if there's a date for it yet, Shona.
There isn't a date. Thank you for pointing that out. We are currently looking. Have we agreed that this will always be on a certain day of the week, or are we?
No, I sincerely hope not, because I wouldn't want it on
fine.
Thursday again, because it's a lot of our rehab team couldn't come today because they're in the weekly meeting. Yeah,
we were looking at either a Wednesday or a Friday. We were a bit limited by room availability in March, so that's what we're working on, because we were going to open it to be hybrid, so people could come face to face if they choose, or we will continue to do it online.
So when do you think you might be able to give us a date, Shona? I'm just conscious
I can tell you the potential. Yeah, I can tell you the potential date. Just give me a minute. Oh gosh, can't find it now. It's buried deep. Oh yeah, Wednesday the 13th of March is what we were aiming for, but we're struggling for a room, so we might have to go to Friday the 15th, I think, or maybe Friday the 8th.
Okay, that's helpful because at least we can block those dates out, you know, not set up a regional clinic on that day or something like that.
Yeah, I'll double. Georgie was chasing rooms, so I'll as soon as I get a date from her, I'll get that to you.
Perfect, thanks. And then we'll email it everybody out. And finally, Jane, was there anything about the NICE guideline that you're working on for rehabilitation in chronic neurological disorders that you wanted to give us an update on? Or was that just grinding on?
Well, I'd like to think the word grinding wasn't. That probably is exactly what it's doing, but it's actually due to be published.
Slow progress is what it is.
It has been slow progress, but the reason why it's been such a slow progress is because, well, I'm sure everybody on this call will not be too amazed to hear that doing a guideline on all ages, chronic neurological diseases, plus acquired brain injury, plus functional illness is quite an ask. And so it's taken a bit longer than anybody in NICE thought it would take. And in the middle of that, having a pandemic. So yes, 24, we hope to publish it. And
I think that's quite good going.
And between now and then, we must have about 12 meetings, haven't we? So the pace of meetings has become quicker, faster, and more. So watch this space.
I know it'll be embargoed for quite a while, but when it isn't embargoed, we must get you to present it. Yeah, cool. Okay, does anybody else want to ask anything or raise anything before we close? I'd just like to thank everybody again for coming and for staying on till the bitter end. And thanks to Jane for organising the meeting, and Helen and Shona and all the Tash and all the speakers. Thank you.
And thank you for giving us the opportunity to collaborate. I think that's really nice to bring the specialties together. It's wonderful. Thank you.
Great. All right.
Nice to see
Thank you very much.
friends as well. Bye-bye.
Yeah,
Take care. Have a good afternoon. Thank you.